What if everything you thought of health and wellness suddenly changed due to a hidden breathing problem that you were unaware of that affects every system in your body? Improper breathing habits are often overlooked in medicine. I'm Dr. Jenny from the Hobson Institute, and this is the Breathing Lab.
If you look from the side, you're looking at the curvatures. If you're looking from this one, now you're looking like we cut you in slices, the rotation, that rotation will go away too. That causes all sort of pelvic girdles problems, which I try to stay out of.
So the twisting is just to disengage your back.
It's disengaged. It just says, let it go. I tell them we call it dancing. They said, yeah, my husband will never go dancing with me. So now, let's go back to this picture right here. So now we have the head, the jaw, the hyoid bone, all the muscles. The jaw, we put the cotton rolls between it.
Yeah.
And we open and close a few times.
Yes.
Now, right now, you're in a little waterbed.
Yeah.
Your muscles are relaxing, your jaw is floating wherever it wants to go. You're still disengaged completely from your teeth.
Yes.
We'd like you to be able to engage your teeth and stay on the same spot. But if you take that out for a minute and bite, try it. You're going to feel like your teeth hit wrong.
Yeah.
And why are we doing this project? There's all these people who are saying occlusion has nothing to do with TMJ.
Yeah.
How stupid. What do we do 2,000 times a day?
Chew.
No.
Breathe. Swallow.
Swallow.
Yeah.
When we swallow, if we swallow correctly, we bite our teeth together when we swallow. Bite together, swallow. Little difficult? Not normal. Bite, swallow. He's having a hard time. The two most basic things we do with our jaw is swallow and breathe.
Yeah.
And it's not working hard for either. And how many of you have scalloped tongue? You have a scalloped tongue? You do, I know. Just let it ride. No, just don't
Stick it
move
out.
Just open. Don't even stick it out.
Yeah.
Just open.
It is.
Yeah, a little bit. Let's see, yours will be worse. Open. Yeah, you've got a huge scalloped tongue because your tongue is always between your teeth making an appliance. But what does that mean? If your tongue is between your teeth to make an appliance, it pulls your hyoid bone up. If you pull your hyoid bone up, you have stretched the super and infrahyoids. Do they like to be stretched?
No.
These So now what you do is you compensate. But that's good because that's what muscles do. So we compensate by bringing our head like this. Now everything's in balance, but now we're looking at the ground. So now we rotate on our atlas axis and we have a problem.
Correct.
And we have a forward head posture, not tell them to push the chin back. So I don't tell people to push their chin back because the jaw belongs forward.
I've been working on that with Chris Consolo. Swallowing with vegetables. He's having a hard time.
Swallowing with what?
With some carrots or crackers.
Yeah.
Okay, so let's go and talk about where you should stand. What is it? Do you have a good posture? Well, you know you're right to left.
If it's anyone, it's Jenny and all of us to have a
Stand
better.
with your heels against the wall.
Because she's always.
And then we're going to put your shoulders against the wall. We're going to make your head straight. Now, you should have two fingers, so push your neck against my fingers, but don't tip your head down. Now push your back against my hand, because you only should have that amount there. Now push this here again. And now we're just going to level your shoulders and push you back. Would you ever stand like
Get your knee like this right now.
Take your mask off just for a second. Open. Put it back or put it back. Is it easier to stand like that now? Now you got two fingers. Just back a speck. Almost perfect. It's easier just because your jaw is not in the wrong spot. But what we teach everybody, you've had kids, you know Kegels. Pretend you have a really full bladder. You're about to lose it. Any second. It is so close. Oh my God, you can't believe it. Squeeze your perineal muscles and your butt so you don't do it. Now you're perfect. Perfect. Most of our patients are women, right? I tell them you got to do Kegels all the time. All the time. Driving, eating, walking. You have to, if you're going to build something, you build it from the top down to the bottom up.
Yeah.
So you want to get this right.
Yep.
And if you have perineal problems, are those the worst patients you ever see? They're pelvic floor specialists because nobody wants, and to do it right is really hard.
I remember Liz saying, like, if you're clenching here, you're clenching here as well. That's what she said.
Yeah.
So,
So you can, if you want to take the cotton rolls out, they actually kind of feel good in there. Now try it again, the cotton rolls out, and just do the Kegels. So this is right, but now you got three fingers instead of two. Three fingers instead of two. So all we did is disengage the jaw. Of course, now you're also way off center here, and your head's tipping way to the side.
Yeah, my head always likes to go left.
Okay, so so we'll show you other things to do.
Yeah.
But this is just every single patient. The reason I go to have 2-hour consults,
It's because you go through this.
everything's important. I don't know what to leave out.
Right.
If I was smarter, I'd just tell them what they needed to know. But
Is this
I
the
don't know.
exercise you said to do where you have them push into the wall like this and do Kegels there?
No,
You said
I
there
just
was-
have them stand against the wall and now do Kegels. They're two different exercises though. The one exercise is just to stand against the wall so you know what straight is.
Mm-hmm.
Because you didn't know. How long have you been teaching physical therapy?
Long time.
And you don't know what it feels like to be straight. Now, anytime they find a wall, all they have to do,
Lean against it.
this is straight.
Yeah, yeah.
It gives them a baseline.
Yeah.
And if you push the chin back, it feels, here, go back against the wall.
She's
Be straight.
I know she's trying to.
Now we're going to push your chin back. Doesn't that feel good? And all the physical therapists want people to push their chin back.
We do that all the time. We tell them to do that.
I know, it makes me crazy. The first thing I tell them when they come to my office, don't push your chin back. That's why I teach them against the wall, because they can feel it. They're not pushing the jaw back. I don't want the jaw back.
Okay.
That interferes with their breathing.
So what we've learned is that if your head goes forward, your jaw goes back. If your head goes back, your jaw will
goes forward.
compensate and go forward.
I'm going to tell you, I think that's true backwards.
Yeah.
Because the most
So
important thing we do is
head posture.
forward head postures to open our airway.
Yeah, but it'll bring the mandibles back.
It's a compensation, but
Right.
it's opening the airways. What we want to do. If you bring your jaw forward, you open your airway.
That's right. That's what like I'm telling. So some of the patients when they go forward, their mouth is actually open while they're talking to me.
Yeah.
Mhm.
But when I push them back, I actually like their jaw better because now it's not either clicking or not in pain. Because when it's forward, it's kind of the disc
Right.
is at very
So
precarious
I
position.
want their head back,
Mm-hmm.
but I don't want their head back by pushing their chin back.
So
Okay.
it's just another way to look at it. If we can get their heads back.
Back. Okay.
Right. So all I do with this whole exercise is so they have a baseline that they can
So
feel.
this is what we give them is chin tucks. It's just this.
It's just rotating kind of
Yeah,
head.
so when you send
So
your
you-
patients to me, I probably tell them not to do your chin tuck. And I'll tell them do Kegels because it'll, again, stand against the thing, feet together,
Feet together.
and just do the perineal, the Kegels, and tighten your butt cheeks. And the nice side
Does
effect
she have to
is,
disengage her jaw too?
no,
Or
you can keep them together apart, it won't matter. If we disengage the jaw, it's easier. You have an equalizer, it's
Mhm.
easier. Now, the advantage to this, how old are you now?
45.
You know what happens to 2/3 of the women by the time they're 55 to 60?
Incontinence.
Yeah, they end up in diapers.
Yeah.
You see all the commercials on TV for diapers? Guess what the cure when you're young enough to do it that you do not to need diapers?
Kegel.
Kegels. So you have two choices. You can do diapers later when you're older, or you can do Kegels now. Which would you rather do?
Kegels
Kegel
now.
now.
Kegels. Now the good news is, if you watch the commercials, they now make sexy diapers.
I know.
They have so many commercials for sexy diapers for women that you don't see under their dresses. They're still diapers. And sometimes people have other issues, so you have to be a little careful, but that's what I threaten people with. And then I ask them, does your mother have problems? And they always say yes. Because if they have posture problems, most of their mothers do. If they have posture problems, they have incontinence problems.
Yeah.
And it's because they have weak perineal muscles, weak pelvic floor muscles.
What if your occlusion, one of the things that I did was I expanded with an ELF and then I kind of stopped treatment.
Okay.
So my teeth don't perfectly fit. They don't interdigitate.
So when you start to close, as soon as your first contact comes into contact,
Yeah.
your muscles adapt to avoid it. And you can't even find the first contact.
Yeah.
So let's put you on a 10, you'll be the client,
Okay.
and we'll show you what your jaw does where you're at since we know you have a problem. I'll be right back.
Okay. So I worked with Dr. Crow for a while,
Mhm.
and then we got to a point where he had me on a lower appliance for like 2 years.
Wow.
I ate with it. I liked it. That vertical helped my back. My back felt better with that height.
You have makeup
Um,
on?
No,
No.
I was telling him that I like the vertical that the lower appliance that I worked with him gave me. I did it for 2 years, and then he started taking it down, and then my back started hurting.
Well, you can stay there. You don't
Okay.
have to move. This is portable.
So anyway,
You use all sorts of 10s, right?
Not
some,
right now.
Not much now.
I went to John Kelly.
Okay, so he had to do it on one of these.
Yeah.
What are you applying?
He
Dr.
showed
Kelly
me.
does
He
that.
showed
He
me
uses it.
how to use the 10s with a patient, but I only saw him once do it, and I've never felt it.
Is the TENS just for pain control, or are you looking
No.
for like
The
the
10s is an
functional-
ultra low frequency 10s.
Uh-huh.
So it pulses every second and a half, 90 seconds.
So this
When
is a
you
different kind of TENS then?
This is
just the
this is the
standard
same as the one
transmission.
Dr. Kelly uses. It's not a standard TENS. This is ultra low frequency.
Okay.
Ultra low.
Standard TENS is usually 2 to 2,000 frequency. Or
It's
2
a
to
more
4.
medium frequency one.
This is
Transcutaneous
ultra
the-
low.
Okay.
This is ultra low frequency. Let's see.
So it's to
What's the goal
reduce
of this?
hypertonicity if it's not for TMJ pain?
Functional versus the
We do
anatomical.
lots of different things with it.
At least that's what Dr. Kelly does.
Yeah.
Right?
Okay, open your mouth just a little bit.
Ah.
So if you
Maybe
put your
it's
finger
easier
on her
to
chin,
take the-
put your finger on her chin,
I'm open, right?
just open a little bit.
Mhm.
Can you feel how the jaw moves each
Oh, yeah,
time?
yeah.
Okay,
It's going
so
kind of like.
simultaneously, every time it contracts, every pulse,
Oh, yeah.
you're relaxing all 16 mandibular elevators.
Wow.
What they're doing is they're going to contract and relax, contract and relax. When the muscle contracts, the waste products built up in the muscle get pushed out. When it relaxes, you bring in fluid.
Mm-hmm.
So I'm going to say naturally relax the muscles by increasing the blood flow in and the waste product out. You can have the best nutrition in the world, but if it doesn't get there,
What's the
what's the point?
How long is the
Sometimes.
treatment?
Me neither. I thought it was just
It's
a
a
regular.
treatment.
That's what I thought. And
What's
I
that?
think
It's
he's
a
going
treatment.
even for the.
How
Well, I
long?
do it as part to find the right spot
This
for
one
the
is
jaw.
3, right?
It's to find the right spot in
If
the
we can
jaw.
find where the muscles are relaxed on the jaw, we can measure it and build people there. And we can actually put them within a microsecond of equal contact on both sides.
And this is where I would put like those 2 separators.
Yeah, so is it too big, too small, or they bring it into the right spot, forward, backward, side to side? I would tell you put an aqualizer in, it's going to be more accurate. They come in 3 different heights, but I always use medium.
Medium and mini.
Medium, I think.
And mini.
Not the mini and the ultra are both medium. They have a slim, which is neuroocclusal,
Yeah.
and they have the ultra, and then they have it in high fill, low fill, and medium fill.
Oh.
Which
Which one do you use then?
The ones you have are all medium fill.
Okay.
And it's because I buy them 50 at a time, and it's like, I don't want to have to pick and choose all of
Yeah.
them. It's easier just to get a whole bag of the same.
Yeah.
What do you do for people who destroy the equalizer?
How fast are they destroying it?
Like,
I tell them not to sleep in it. 2 weeks is a long time. It's the ones that destroy it in 20 minutes I worry about. If they destroy an aqualizer in 2 weeks, how much does it cost to park bait when they come to visit you?
it's about, well, $20.
It's $39 for an aqualizer. If they save one visit once a month by having an aqualizer versus not, it's paid for by parking.
Yeah.
It's, things are expensive. I'm going to show you the office across the way, though, because if you decide you want to do stuff here, you're in the middle of the North Shore. You got Lake Forest, Highland Park, Winnetka, and it's like,
I know you told me
money's
about
here. I know.
it. You know what?
It's, what?
Jenny, how long is
Get
that
a lot of
treatment?
public aid patients at the hospital.
What's that?
How long is
You won't
that
get any
treatment?
public aid
I mean, is
passes.
that's a
Why don't
treatment,
you
right?
see public aid patients?
It's to relax the muscle so he can work
Right.
with the position of the mandible.
So
I
do you
feel it
sit
more
with
on
it?
this side than this side. Does it matter?
Ken, have you had one?
Do you, Jenny, do you sit with it for 15
How long
minutes?
do
You
you
never
sit
not
with this
sure.
thing?
I don't know
Usually at least 45 minutes.
45 minutes.
At least.
Okay.
And we'll actually show you measurement.
Already
We'll actually do the scan,
Okay.
a scan to show you what we're looking for.
Okay.
Oh, yeah.
Okay, so when we look at the position of the head to the jaw, how I describe it to patients, I'm going to take your pen. If you get on the doctor scale and you set the 50-pound and the 10-pound and the 1-pound, so perfectly balances on that doctor scale. If you move that 1 pound just a little bit, does it get a little bit out of balance or does it go clunk? It goes clunk. If you go the other way, it goes clunk.
Mm-hmm.
So what I tell them is, I have a diagnosis for you. You've been clunked. You're out of balance.
Okay, cool.
We've already shown them the aqualizer. We've already shown them the arm strength. We've already showed them what happens with their feet. We usually haven't had them go up and down the steps yet. You ask whatever question you ask, you pulled me out of my order. So this is where the strength is coming from the scalenes very deep in the neck.
Mm.
But they have a very definitive spot on the forward head posture. And if you're breathing, if you overbreathe, if you're breathing wrong, they lift the whole rib cage.
Yeah.
If they're doing it all the time, you're going to have a forward head posture.
Mm-hmm.
The cure for that is the diaphragm breathe. So we
Yep.
really push breathing
Mhm,
correctly.
Mm-hmm.
So then Here's the question you asked before that I didn't answer.
Mm-hmm.
Straight out of Travell, thoracolumbar chapter. If you look,
Leaning, I think. Yeah.
when the long leg, short leg, the person will almost 100% of the time take their long leg and hold it off to the side. If they don't have a specific traumatic incident, almost 100% of the time, the leg that's going to need the knee and the hip replaced is the long leg.
Mm.
Every time they take a step, it takes a little bit bigger beating,
Mm-hmm.
but so does the whole body. So I'm going to go walk with a long leg, short leg for a minute. Just come on over. You can take the computer with you. So now I took off one shoe. I have a long leg, short leg. So now if I walk, I don't compensate. That's what I'm doing.
Mm-hmm.
But that's not good. So then
You walk on your tippy toe.
I can walk on my toes, or
That
I can do
one.
this. Now I have a hip problem. So you compensate. That's the problem. So the question now is, if they really have a long leg, short leg, do they need a lift in their shoe?
Right.
How do you know? How do you know? How can you tell a
The
real long leg, short
aqualizer,
leg?
if it evens it out, you don't need one.
That's my point. That's why we're doing the
Yeah,
study.
yeah.
And then we're going to hopefully a whole lot of studies.
Yeah.
But what it says is the problem is occlusion.
Yeah.
And if the problem is occlusion, then we have to correct it. The problem is airway. So it's to put it together. I use it diagnostically all the time, and I use it to educate patients. But when you try to walk with one, try to walk with no compensation and with one foot off, on or off. Just don't compensate. And if you walk with more force on it, you'll feel it whacking down.
Yeah,
It
yeah.
twists your whole spine out of whack.
Oh, of course, yes.
But we compensate automatically. How long does it take us to figure out how to compensate? About 2 steps. So now, as doctors, as physical therapists, as physicians, everybody's treating the result of compensation.
Yeah.
Yeah.
Let's get rid of the compensation as much as possible.
Yeah. My pelvis has always been like, one side has always been a problem. And I'm thinking that it's part of my occlusion because my bite has been always up. I'm like a bicuspid.
It's very, very possible. Yes.
And now my bite is not, you'll see, it's not right.
Okay, so let's come back here. So again, this is how I explain it to patients, but it's also what I teach courses. To doctors, I teach them the same thing because most of them don't get how it all comes together. So, here's the picture. If you look on this side, the person has a compensation. The long leg is held to the side. In the middle picture, the 2 legs are together, and now you can see the pelvic discrepancy. And then on the far right picture, there's a book under the foot or a orthotic under the foot, and they're even. The important thing, look in the middle picture and look at the spine. You see the curvatures? There's 3 curvatures typically. It can vary.
Mm-hmm.
The curvatures, where there's a curvature, the inside of the curvature, the muscles are tight. So on the inside of the curvature, you're going to get muscle pain, which is dull, achy pain.
Mm-hmm.
But if you get sharp shooting pain, it's going to be on the other side because the muscles being tight push the disc out of position where it presses on a nerve on the opposite side.
Mm-hmm.
And it can move around as we compensate, so it kind of moves up and down the back.
Right.
So where you get the pain is on the inside of the curvature is the dull, achy pain.
Mm-hmm.
And it's like, well, we all know dull, achy pain where it's at, but why does it move around? So we spend our time chasing it. So the spine, I tell people it's kind of, the chiropractors have the hardest job in the world. Because I have a 6-foot piece of rope and a 5-foot arm stretch, and I want to hold it straight. Can I do it?
No.
What if I tie one end to the doorknob? Easiest thing in the world.
Yeah.
So the spine, there's 3 set points in the whole body. Our tushies when we sit, our feet when we stand, both go through the hips, and our teeth when we close. There are no other terminal joint spots in the whole body.
Wait, repeat that again? I'm sorry.
The 3 spots where we have a definitive spot. When we stand on both feet, that's a permanent top. We can change it by moving our foot to the side. When we sit on our tushies, our hips, and when we close our teeth together. Those all affect the spine. So if you think of the spine like being a slinky, the big, remember in high school we'd play with the slinkies and we'd stretch it out and make the waves go up and back? That's what happens when you put the aqualizer in your mouth. Those waves go up and back and the muscle says, oh, I don't have to compensate. And what do our muscles want to do if they can do? They want to use as little energy as possible and relax.
Yeah.
So and it's just now my whole field from medicine in general. Is doctors don't heal people. We remove the impediments to healing. If we make an environment that they can heal, people heal.
Right.
If you cut people open, that doesn't heal anybody. But after they heal, if you cut something bad out, they can heal better than they were before.
Right.
Excuse me, Dr. Shapira. Do you have a restroom?
No, but you can go to the back corner of the building. That's all.
I can do that same
No.
thing.
You're a guy. Yeah, just go to the left by the water fountain. So this is what we did. So this is what we did with you. You stood.
Yeah.
Then I made you put your feet together.
Yeah.
Which you normally don't do when you have a long leg, short
No.
leg, because it'll make you cause you. First thing you get
Right.
is low back or pelvic pain.
Yes.
And then I measured your hip height. Then I put something under your foot to level you off. I wasn't all that perfect, but it was just much less
Than what you
wrong.
had.
It was less wrong. I checked your arm strength, and then I took it away and checked it again. And you went from strong to weak instantly, but that actual strength to weakness was still in this area, in this place, in this area. It just traveled through the whole body.
So we are, look at this, what you showed us, you're testing hip height from the front. We do it from the back.
That's fine.
And we don't test the strength. Should we start testing strength?
You can, but right now for the first thing,
Yeah.
if all you do is have one effect, it's an easier paper.
Yeah, that's okay.
If you're
that's
treating
what,
people
so,
clinically, once you've done that first test, now you can do the strength test, and I would do it with the with and without.
with and without the aqualizer, with the feet
So do it
together.
with the aqualizer first in, and then take it away.
Yeah.
But
And just straight out.
first do your recording before you add anything. Do it first, because now you have some pure data.
Yeah.
You get a new patient, you look at their hip height. This is what we saw. Put them in an aqualizer. This is what we saw.
Yeah.
Do I want to do all the rest of that? Oh, I want to get everything done, but you need a starting point. If you can get the first study done, now we have a basis to build on.
Yeah. Okay.
And all that stuff that you saw from Italy was never published. Yeah. So, so if we get to 20, 25 people, we can do a preliminary little study.
Okay.
And it's all, I'll write it with you, but it's all coming from physical therapists who are doing all the measurements.
Okay.
Because nobody trusts us. They think we're all biased. Well, maybe we are. But. So same thing happens if you sit. You ever have a patient, you don't sit on your wallet, it's causing your back pain?
Yes.
Okay, so people, if they have a high hip and a low hip, and you compensate, you cross your legs.
Yeah.
Makes you feel better. Or you can put a book under the thing or a pillow under the thing, and it feels better.
Yeah.
If you have a person who's got chronic back pain and has this uneven split.
Yeah.
Now, funny thing is, they have an uneven split when they stand, and when they sit. You can check both. We're not doing that yet. We can do it later. It just complicates things with too much data.
Okay.
Usually, but not always, the hip heights are also correct when they're sitting.
Also correct when they're sitting.
Because it's a functional short leg, not a structural short leg.
Right. That's right.
The worst patient you will find is the ones who have one long leg when they sit and the other long leg when they stand. Because now every time they change position, the whole body has to coordinate to it. If the aqualizer equals everything out, life is easier to treat. So, but it's not a good long-term answer.
Right.
It's a wonderful band-aid and diagnostic tool. So that's the basic thing we just kind of teach everybody. We tell everybody that the pains in the pictures are frequency diagrams. You know what a frequency diagram is?
No.
But you see these pictures all the time.
Yeah.
That's not one person.
That's many people.
That's thousands of people. And the darker the red, the more frequently they have that pain.
Yeah.
But in any one given patient, they may have pain to the tip of their big toe or the tip of their nose, These are the most common patterns.
So the
So
darker the color, the more of the people have experienced.
the more frequent it is.
Yeah,
They're
yeah.
straight frequency diagrams. If you don't, you all have Trammell's books?
Yes.
Yes.
Okay, great. If you didn't, I would tell you don't buy edition 3, buy edition 2.
Oh, okay.
The new edition is dreadful compared to the old. So, go to the bottom of the feet, same thing happens. You can get pain to the heel, to the calf, to the low back, from the soleus muscle. Makes perfect sense. That's a frequency diagram. This is a case study of one. Same muscle, except it hurts to the face, hurts to the jaw, to the eye. Which is your long leg? I forgot. Stand up for a minute.
Right leg.
So right now, it's had a chance to heal. The muscles are more relaxed. Is there a spot that hurts there?
Yeah, the way you hurt. I think everything is.
You've been walking on it for how long? Lopsided. But that can refer to the low back, to the hips, to the feet, and it can also refer all the way up. If you follow the Chinese meridians that they use for acupuncture, everything goes top. That's kind of just a very basic thing we're doing with everybody. And then, you still have pain in your low back?
Yeah.
So stand up, put your feet together. And you've done the aqualizer thing on yourself?
No, actually, I haven't.
Okay. So if we put my hands on your hip, you're more off than she was. You got a high hip and a low hip. You're also forward and back. So we're going to put you on the carpet because there's more room to hold your arms up. Face me. That's together. Now I have you level. Very close. Right together and don't let me push it down. Just one finger. Don't let me push it down. I can do it 1,000 times. Some people, there's a trick. The trick is we went from healthier to less healthy.
Yeah.
So we're grabbing out. Do you have another appetizer?
I don't.
I have any menus, so it doesn't matter. I'm out of them. Just used my last one yesterday. So I'll let you put it in. You put it on top or bottom? I like it better on the bottom. Actually. Most people think it's more comfortable on the bottom.
Really? I have been always putting it on top.
I didn't know.
So,
I didn't know you can put it in
And
the
if it makes your mouth sore, you can flip it.
oh,
Okay, so all we did right now is make you even. Stand with your feet together. All the way together.
can you see, Kathy?
And now,
Yes.
right together.
Thank
Don't
you.
let me push it down.
No.
Now you're strong because you're balanced, but you're still lopsided. So now, with me,
Let's walk it.
down south.
How do you test
We should have
that?
took a picture.
You can do it.
Yes.
In the study.
Okay.
Sorry, all we did.
I'll do it on the Tuesday. You can take a picture of me.
Sounds good.
And you really want to stay away from people who just get.
I'm surprised. Why did I never mention about my left jaw pain? We never talk about that, right? Because it happened so long time ago. I forget about it.
Explain, it understands why things are wrong. So we don't really know what we're gonna see when you get back.
Somebody else.
Stand up. Just one up from down.
Next way, feet together. Okay, are the hips even now?
They feel even.
But they're still rotated. So we just have to let them. They're not perfect, but they're close now.
So just shake, 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 shake,
Don't
shake.
do the twist.
It's easier the Dr. Crow's.
The shakedown.
What does the crow do? I have never
The
seen.
nut and bolt.
Ah, the one that you do, Jenny.
Yeah, I like that one too.
Really?
But-
Okay.
Okay, so.
But it's just shake,
it's
release
just-
everything.
Yeah. Women are better at that than men. Men have a really hard time of letting go.
Oh, my
Okay.
husband is a robot. Doesn't
Now,
know
right
when.
now, your head's still tipped.
Yeah, and it's always tipped to the left, always.
Just sit. Right there, facing right.
Oops.
Okay, but you're also even when you're sitting.
Sitting.
I'm gonna just leave this in because your head, hopefully it'll separate, come out a little better by the time you leave, but right now we're not doing anything permanent, just the appetizer. Okay, so this is not my part of the body. That your book
No,
two,
she's still there.
Okay, so the quadratus laborum basically is your muscle.
Mm-hmm.
It's
We
like,
needle that one like crazy.
what's that?
We needle that one a lot.
Okay,
Especially on her.
Yes,
See,
especially on this side.
Okay, the problem with needling it Because if you haven't fixed what's causing it, the problem comes back.
It
So
always
pretend you
comes
have a nail in the bottom of your shoe,
Mhm.
and you're walking around and it's killing you. So you start to walk funny, a little bit different, so the nail doesn't hit. You twist your body, and now you can walk with the nail in your shoe without it hurting you much.
Yeah.
But the bottom still hurts you. Your whole body's twisted up. But that's okay, because you're going to the physical therapist, who now loosens up everything. And as you get ready to leave, you put your shoe on with the nail back on.
Yeah.
You've got to fix the
Original
Yeah.
cause.
original causes. So the subscapularis muscle coming up in here, I don't really work with it, but I show stretches for it, and I'll show you some of the stretches we show people. But
Do you spray and stretch this thing?
I spray and stretch everything. Everything that happens with movements, so when we look at people, so this is the same information.
Yep.
This person has a curve in his spine.
Yep.
If you support his hip on the side that's low,
Yep.
you straighten out the spine. If you put it on the other side, you make
It'll
it
make it
worse.
worse.
But if you straighten out the spine from changing the mouth, and this becomes even, that's better yet. That's a fixed point we can change. So now, this same thing. If you have somebody who's high hip and low hip, now you support that. That's what we just did.
Yep.
But what if you put the lift in the wrong shoe?
Makes it
Well,
worse.
this happens all the time. People come in and in a moment in time, you examine them. And in that moment in time, the way that corkscrew, because think about the spine like a corkscrew, the twist of the corkscrew at that minute gave them a long leg and a short leg. But the next day it switches, except they have that lift still. So I watched Janet Trevell. First time I heard her, this is why I fell in love with her. It was a whole room, 100, 150, 200 oral surgeons and me. I was the only general dentist there. And she's teaching about myofascial pain. Everybody raise your hand who has back pain. 2/3 of the room raises their hand. All the dentists have back pain. How many of you have a lift in your shoe that helped your back pain? Probably 30% of them raise their hand. How many of you have a lift in your shoe, but you still have back pain and it's been years? A handful of them raised them up. And she pulled up the first one and the second one. The first one she pulled up, I was gone. She brought him up, checked him with his lift, and he was even. Then she worked on his back for like 5 minutes and relaxed the muscles. And she had him stand, and he was like this with the lift.
Mhm.
Then she took the lift out, and he was even. Then she worked on for about 5 more minutes, and this man who had back pain for 40 years was out of pain. The lift that was put in a moment of time when he needed it was the wrong thing later.
Yeah.
So why do I care about the aqualizer and leg lengths? Because if I make the bite perfect, but I don't have the spine right, as the spine straightens out, what
The
was
bite will
right
be
is going to
off.
become the thing that keeps it from getting better. That's why everything
That's
we
why
do
I
is
thought
diagnostic.
When you
initially.
disengage this and it improves it, it makes you think that
Right.
the occlusion is the reason why
Right.
there's a problem.
Right. So Mariano knows more about the physical therapy, but but I know down in South America, a lot of dentists mad at him because they think he's taking over their TMJ cases.
Right.
And that's because they don't know what they're doing, but they need to work together,
Yeah,
and they
yeah,
don't.
yeah.
They became adversarial.
Yeah,
down there.
yeah.
So this is one spot. You can do this in stick versions. I like stick versions where you can see what happens with different things. So if you actually have a structural long leg, short leg, and you put in a lift, where you're going to even out the things, but you're not making everything else better, especially like on a scoliosis patient who's been that way for 40 years. You got to be careful. But if the muscles are relaxing and they're evening out, now you're on the right thing.
Mm-hmm.
If you just put a lift, but you haven't worried about relaxing the thoracolumbar muscles, what are you doing? And it's like, so again, this is not my part of the body. It's definitely yours. And again, it's not one direction, it's two.
Yeah.
If you put the heels, the hips, the back, the neck, you're going to have 2 fingers, you're going to have the hand in there, it's going to be right.
So behind the head should be 2
2
fingers.
fingers.
And then behind the back should be
I put the hand flat.
just a hand flat. And you should feel the hand against your back and the 2 fingers.
Yeah, it's hard. If the patient's doing it, I just have them stand against the wall
Yeah.
and go do Kegels because they
Yeah.
feel, and then take a step away from the wall while doing Kegels.
No,
Oh, hold on. Can my feet be together or no?
Ideally, yes,
Yes.
but since your hips may be off and you're doing it, we're not going to worry about it if you haven't locked up and on the stuff with the aqualizer yet.
Oh, so you have to do that
You do have
first
some
before you.
You don't have to. I don't put an aqualizer on everybody, but it's like, but if you had the appetizer, then you should do your feet together. Otherwise, we're looking at an accommodative position. But you're still looking at this posture from that sagittal view, you know. So everything happens. So everything down here, though, translates all the way up the spine, to the head, to the neck, to the jaw. So every distorted pelvis, the angulation, the twist. Again, this is showing it two-dimensional. This doesn't even show the twist. It's just two-dimensional. And so as you change things, what we're trying to do is get rid of the curves and make things right. That's what the appetizer does.
Just because it disengages and it gives you a little moving,
It lets the
flowing.
muscles relax because it's hydraulic. It's always balanced. So if you look at the whole, here, give me your paper and your pen. I'm just going to take a page and draw a picture. So here's the head. Here's the spinal column. 20% of what comes into the brain comes from the spinal column, right? Where's the other 80% comes from? 80% comes from 12 cranial nerves. So we have, you remember an old Olympus towering top, that's how we remember them, otherwise nobody would know them. But sight, smell, taste, hearing, vision, proprioception, vagus nerve is a huge one, but the biggest one is the fifth cranial nerve, or the trigeminal. So the trigeminal nerve has 70% of the input to the brain of that 80% after it's been amplified by the reticular activating system in the brain, or a little more than half the total input to the brain.
That much. Huh?
That much.
So more than the vagus.
It's got more proprioception than the rest of the body combined from the mesencephalic nucleus of the trigeminal nerve.
I guess that makes sense.
The vagus goes to the gut and the heart.
Mm-hmm. Yes.
So the vagus, so this is the somatosensory nervous system. That's the one we're always working with, that you work with, that I work with. I also work with the autonomics. So if you work with the autonomics, vagus is a big autonomic.
Yeah.
It goes to the gut, the heart. So we have two. We have sympathetic and parasympathetic. What's the sympathetic?
Fight or flight.
Uh-huh.
Let me see if that's not.
It's like go get her in your phone.
Maybe it won't be good. So the sympathetic is fight or flight. Survival of the individual.
Yep.
Parasympathetic is yin and yang. It's the feed and breed, or rest and digest. They're always in a balance. It's never 100% one way or the other. If you get all stressed out, you get stomach problems because you're sending all your blood to your brain and your muscles and nothing's going to your gut, so it's rotting in your gut. You know, this is what's going on at all times. If you want to get somebody into sympathetic, have them play with a bunch of puppies or kittens or babies. Everybody starts to ooh and ah. Even the big, more burly, nasty people can't help themselves. Pushes them right into the parasympathetic nervous system. So both of these are acting all the time.
Yeah.
So if we look at the trigeminal nerve, it has three branches.
Yeah.
We have the ophthalmic branch, we have the maxillary branch, and we have the mandibular branch. Mandibular branch is the motor branch.
Yeah.
Where we're stimulating you right now is on the maxillary branch. However, there's a feedback loop. So what happens, it's a single reflex. So if you put your over my thing, if I do, that's a reflex. That's what this is doing. You can't control it, stop it. So you can't control it, it's happening all the time. All the time we just delude with our reflexes, but that's good because they protect us, except when they don't. So when we pulse you, we pulse the maxillary branch, but we get the movement in the mandibular branch. The muscle contracts, relax, the waste products come out, the muscle relaxes, it will return to its resting line all by itself. It'll do it faster if you have an appetizer in their mouth, because every time they do close, they always hit perfectly balanced. Okay, now on the maxillary branch, So you can't see it here because you can't see the top of the skull, but the foramen rotunda comes out into the pterygopalatine fossa. So there's a little pyramid of bone here. The pterygopalatine fossa is the inside. Inside of there, you have the maxillary branch of the trigeminal nerve.
Is that open?
No, this one doesn't. The maxillary artery. At the other office, I have a real skull, which does. You can see all these things better. We have the maxillary artery, and we have the sphenopalatine ganglion. So the sphenopalatine ganglion is the largest parasympathetic ganglion of the head.
It's
So-
the one that they do a block on.
That's the one I do lots of
Yeah.
blocks on. So it
That's
sits on the maxillary artery. So you can do an injection through the roof of the mouth and go right into that area. You
So
can
that's
do.
how you access the SPG then?
That's not how I usually do it. But if I have a patient I'm getting numb or taking a tooth out on and they have chronic pain, I'll sometimes inject them there. I won't even tell them I'm doing it because it's part of getting them numb for the extraction. And I'll just walk away and say, yeah, if this makes a lot of your other chronic pain get better, come back and talk to me. You can do an injection where you do it through fluoroscopy, going through the muscles. It's really hard and crazy expensive. You spend thousands of dollars. Or it's very easy to come in with a long needle through here and do an injection. There's nothing you can hit that's wrong. It's extremely safe, and you can block it there.
So that's how we do the
Lateral
lateral
pterygoid through
Well,
the,
oh, you're doing it through here?
Yeah.
you can do
right,
it.
right, angling it down from here down.
I know most of the times.
Oh, when
I
you're
do it.
dry needling.
Yeah.
Yeah.
Okay,
But no injectable.
right. So
Would that help?
yeah, so when I do it, I would put something between their teeth like this,
Yeah.
and I inject it from here.
So we'll do that too.
So because it goes from the lateral pterygoid plate to here.
I
Yeah.
actually do this one.
You do the
I do this
Yeah.
one. Yeah.
But I always open them up when we do it.
Yeah.
And then sometimes we will go in through the mouth and we do it. Who's the guy downtown? This is what Goldman.
Okay.
He does, I can't remember whose technique it is, but he taught it to me. And when I have a really tough, bad lateral pterygoid, we'll do injections this way,
Yeah.
through it, right to the neck. And then you go lengthwise through the muscle, and it's really more like dry needle. I don't dry needle very often, but I do. But I don't use your needles. I use hollow needles.
They're thicker.
What I tried acupuncture needles, and they didn't cause enough damage. Sounds terrible, but when you create an injury, the body has to heal the injury. And as soon as it's a hollow needle, it's letting the air in, it's changing the pressure, it changes everything's different.
Yeah.
So even when I dry needle with no anesthetic, I'm usually using 25 or 30 gauge long needles.
Oh, that's
30 gauge, it's not, because I can use anesthetics, so I also do trigger point injection first.
okay.
So I will trigger point inject, put a little extra fluid, and then I'll run up and down through the numb tissues.
okay.
So, but it doesn't hurt that much. You can if you get a 30 or a 31 gauge needle, it's pretty darn thin.
It is.
It's pretty thin. So this is the stellate ganglia, or the sphenopalatine ganglion. But that's a parasympathetic ganglion. In the neck, you have the superior cervical sympathetic chain, or the superior, and then you have the sympathetic cervical chain. And there's a whole bunch of different ganglia there. The very bottom one is the stellate ganglion. The stellate ganglion, they do blocks on for reflex sympathetic dystrophy. They do it for complex regional pain syndrome. But they were doing that a lot in the military for people with arm and shoulder pain.
Is that like around C71-ish?
Yeah, it's somewhere down there. It's not a block I would ever do. It's way over my pay grade. But what they found when they do stellate ganglion blocks, which is a sympathetic ganglion block, and a lot of patients, PTSD will totally disappear in one shot.
Really?
Wow.
Well, this is kind of like what happens. So I don't really know exactly what happens, but here's where these fibers go. These sympathetic fibers run up through the sympathetic chain and right into the sphenopalatine ganglion. And then those same autonomic fibers run along all the branches of the trigeminal nerve, and they go right up to the anterior 2/3 of the meninges of the brain where they control blood flow. So it's like, when we do the block here, we change a lot of other things.
Nice.
Wow. You don't even think about that, right? I mean,
And so remember what I told you?
Can
Where
you show us the material you use for the block?
Sure. You can't get them now, though.
One of my patients brought in a totally different thing. And
They bring in a spinal cap.
it was like an inject, it already had the amount in there. It was like a needle that, and then I thought that you had to have a hollow.
There's different things. There's a product that's going to come out called a Relispen, which is actually a little thing for emergency migraine.
Mhm.
And you just spray it. It's got a little piece on it that goes right to the right area. So they may have like a trial early
That's even
thing.
better.
That's not
for
really because it's
people.
just a quick thing, but if you're away from home and you can't do anything else, and if a quick spray will make it go better, it's great. I mean, you see the ads for Ubrevely? It's the migraine drug, and they say, oh yeah, it'll get rid of your migraine within 2 hours.
Yeah.
Well, if you're out having your life, and you take a pill, now it takes 2 hours for your migraine to go away. Is this a cure? It's not even a good halfway decent solution. You know, the Relispen may take that edge off almost like that.
Yeah.
I've tried to talk to the guy, I haven't been able to get a hold of him yet. But I do have some of his stuff on my site, even though it's not approved as of yet. I'm also doing, are you allowed to do ionophoresis? You can't because you don't use drugs.
If you get the permission of the physician that, you know,
Okay.
you have to,
Okay.
you have to get it.
get paid for it. Or
Okay,
it's
so I'm
yours.
done. So far, I've only had 2 people, and they're both my wife and myself, but mainly me. We'll go and put electrodes through the catheter into the thing and then put an ionophoresis
What?
unit. And now we can do ionophoresis
oh my God.
Inside there?
inside. Doesn't hurt, it's numb. You don't feel it.
It's numb because you put.
Lidocaine.
And that
Lidocaine.
increases the passage of the lidocaine. So where do we put the lidocaine? The lidocaine goes right here on the medial wall of the
Wow.
pterygopalatine fossa
I
How
think
do
I've
you
only done
insert the
ionophores.
catheter in there? Through the nose?
through the
Yeah.
nose.
It's all the way, it's like the first
So-
insertion.
Think about it. What's in the nose?
Sorry.
Air, empty space.
Empty space. It's the first, when I do the needle, the nasal release, it's the first one. You just go straight against the palate and it goes
Wow.
all the
Everybody's
way in.
different. Sometimes it does, sometimes each one is different. Every patient's different. Sometimes you have to wiggle it a little, go up and down. So before we do it, we always give them afrin nasal spray, which opens the area. It
Okay.
shrinks the tissues.
Okay.
Then I give them a little bottle the first time because I want them to be successful. We put some lidocaine in a spray bottle and we have them spray each nostril twice, 20 minutes after they've had the afrin. Now the surface is numb a little bit. So now when they're doing it, it's a comfortable, easy procedure. They want to be comfortable, easy
There's
procedure.
a
Some of them are
lidocaine
hard.
spray.
I don't use a lidocaine spray. I don't like
What
it.
did you say?
I just have a little spray bottle and I put
He
2%
said nasal
lidocaine
spray.
in it.
A spray bottle, you just go same thing.
Yeah, I'll show you what one looks like. I just bought them on Amazon. So it works super well. So did your hip still hurt after you went up and down? Because it always hurts, you said.
My back actually feels better right now. It feels better.
Okay, so now I'll show you how I stretch somebody's back. I can just turn the chair this
The
way.
only thing I've ever done ionophores
It's my
is
left
just
Sit
side.
down.
Oh,
Okay, you
I
don't have
trust
to
the
put
way
that
you-
up. Put this a little
Okay.
bit. Spread your legs wide out. Just kind of let yourself kind of drop like a rag down. Very cold on the low back. Just let yourself drop. Don't rest on your knees. And we just stretch segment by segment. Don't stretch like this
Mm.
because you'll hurt
Keep
things.
going.
Good. Come on back up. See, when you're an old guy, that's the only way you get to touch a lady's ass.
So she's side bent to
How's
the
it feel?
right, correct?
Where'd you hurt now?
Reflexes?
Still a little bit here, but this is chronic.
Okay, so let's turn the chair this way a little bit. This sets. This time, instead of going between the legs, we're going to go over the side. So let your arms hang this way. Don't hold on to the table. I won't let you drop.
So that feels better.
This is what to do even for Q&A.
Yeah,
Come on
we're
back.
doing floor.
And it's all gentle stretch. Most of the stretch is your weight.
Feels good. Feels better.
So, and this, we teach patients, we make videos of how to do the stretches
Yeah, yep.
because we want people to feel better.
Mhm. You can do it in style.
So now let's go over to here because I'll show you something else we do that we teach people all the time because they're trying to restore motion. Somebody wants to pop down.
Yeah. someone else.
We'll use you as the guinea pig so you can aim. I'm gonna hit stand right here. Do you ever play golf?
Yeah.
Okay, which way does your backswing go? This typical? Okay, good. So take your, just bring it, this hand to me. Hold your finger in front of you like this.
Yeah, I do this.
Okay, without moving your feet, turn as far as you can, watching your finger. So you can't go any farther.
Have you been doing this one?
Mark that.
No,
spot
I
in your
have no
brain.
clue what it's for.
Come on back to the front. Now this
It
time,
improves your
you're gonna have your hand go this way, head go this
rotation
way,
now.
and stretch your vision as far as you can. Really stretch your vision this way. Going back to the front. Do the same thing again, watching, see how much farther you go.
Now you have more increased
Coming
rotation.
back again,
I did this with Maribel.
opposite
by the way.
directions, and stretch your vision
What
as
is it-
far as you
what's it
can.
for?
Really stretch the vision. Come on back to the
So now
front.
you're not, you're
And do it
keeping
again.
your
See how much farther you go.
So many times do you do it?
visual,
Whatever you want. If you're teaching a golfer, we
what
teach
did
you how
we
to do
use
it
the
with
word?
a-
I'm forgetting.
This hand is the
but you
same
keep
thing.
your sensory input away
Mhm.
from your
Spot. Going back to the
physiological
front,
input. So now you're not
opposite
looking at
directions,
it, so you
stretch the
do
vision
it,
as far as you can.
you go
Vision
more
is the important
further.
thing.
But
Coming
then when
back
you
to the
fall,
front.
you will have even more
See
further.
how far
Now
you go.
you're using both.
And it'll keep going farther and farther. You don't even have to touch people. You just increase their range of motion.
now you're not looking.
relaxing the
And now
muscles.
she will follow.
You're
Now she'll go again.
untwisting the spine.
She goes
You're just
further.
decompensating.
I still don't get it.
Now, look.
So he's saying the muscles relax.
Why is it relaxing her, you said?
Why are we doing that in the first place?
We just probably increased her range of motion 50%. Do you think that's
It's just-
important?
So this is just for range of motion?
Spinal range
What is,
of
what is this
We're
for?
relaxing. The first, okay, that's a good question. The first, we're gonna switch out on the feet stand here.
But your ocular muscles
So the
affect
part
your
of why we do
neck
this
flexors.
is everything we do is educate. Come a little closer to there, so you don't want to hold your finger in front of you just like that. Don't move your feet, turn as far as you can, watching your finger. Oh, come on, you can go farther. Mark that spot in your brain. Mark the spot in your brain, come on back to the front. Now, go the opposite direction and stretch your vision as far as you can. Really stretch your vision. Stretch, come on back to the front. Now do it again and see how far you go. Oh, a teeny bit farther. I mean, double. Okay. Would you really understand how much further you went if you didn't do the first and the third? The first and the third is to give a reference point to the patient, to you. If, instead of doing just this, your hand is going down and your hand is going up in the opposite direction when you stretch, or it's going up and you're going down in the opposite direction, it will relax a little bit different groups of muscles. The point is, we do this so they can see the effect. Why does it happen? It happens because normally where the hand goes, the eyes go. When it goes in the opposite direction, there's no logic to the system, so the brain just says, oh, let's let it relax. It's just applied neurology, really.
Looking away is like.
So this isn't about proprioception or like balance?
This has to, okay, so when you're out,
Because this is what we do with like vestibular.
no, this is not vestibular, this is just to increase the range of motion, to relax the muscles through the whole spine for the curvatures. Same thing I did when I was rotating her hips to relax the muscles. It lets them relax, and can you ask for a more natural relaxation? So it's just an easy way to let things relax. And everything you feel everything changing in your body right now.
Yeah.
Well, you've had that pain for how many years?
15, 20.
Wow.
But we've cheated because your teeth aren't touching.
Mm-hmm.
So it's like, as soon as your teeth are out of it, now you have a chance of getting better. Otherwise, your teeth, they keep bringing you back. So
The teeth bring me back to an
More
imbalance.
aligned.
then your body has to balance. So your head tip is way better now. It's not good.
So, Dr. Shapira,
Well, it's almost perfect. You
Dr.
were way
Shapira has a
lopsided
question.
before.
I think Kathy has a question.
Yes.
so if you, that exercise, I like that exercise a lot. Do you necessarily tell the patient to have their teeth touching together when they do it, or does it not
Maybe
matter?
I tell them not to.
Okay.
Or I'll give them a cotton roll between their teeth, but if they do have them touched, they'll still get the increase, but it won't hold it very long.
Okay.
Because the teeth push them back to their original pathology. If you don't correct the underlying pathology, things keep coming back.
So if I wear this all the time, I'll be fine. That's not
It's
realistic.
not right, but you'll be better, yes.
I'll be better. But when I eat When I
You have to
chew,
take it out.
I take it out.
But normally your teeth don't touch when you chew.
Right.
Normally the only time teeth touch is when we swallow an empty mouth.
Yeah.
Except for you can't swallow an empty mouth with your teeth together. You use your tongue.
So if I were to find a patient that balanced their pelvis after using aqualizer for 3 minutes, we do 3 minutes on the treadmill,
Oh,
Yeah.
and they come back and they're even.
that's what I have been doing. Yeah.
What do you tell them after that point?
That's the reflex. That's the writing reflex. Let's talk about it now.
Okay.
So that was what we said. Why does it happen?
Mm-hmm.
So Sherrington, that sound familiar?
Yeah.
So Sherrington got a Nobel Prize for his work with the writing reflex. I actually bought his original book now, but it's hard to read. It was a series of lectures. But in the simplest way, I'm going to have you stand for a second. So basically, if you didn't have a writing reflex, and I poked you here and you pulled your head away, you'd fall over like a tree.
Yeah.
If you pull over, you'd be off balance and you'd just collapse.
That's a primitive reflex, right?
Instead, what happens is your head goes this way, your shoulder goes this way, your hip adjusts, and you don't fall. How long does it take? How long did it take when I hit your patella tendon to kick?
Oh,
It's
right.
instant.
Yeah.
So that's the first thing. It's a reflex, and it's a peripheral reflex. It's not a central reflex. It has nothing to do with your brain. And
It's a
when you put your
spinal cord
foot
reflex
here, use your brain, and don't kick. Don't kick. Don't kick.
I can't not kick.
That's because your brain is broken. No, it's because the reflex doesn't go to the brain.
It's coming from the
So
spine.
it's a single axon reflex, it's instantaneous. So the writing reflex, he did his work with decervic cats.
Mm.
So what that means is he disconnected the brain, and the reflex was still there. So now you know you have a peripheral reflex. In babies, you ever see a baby?
Mm-hmm.
They try to stand and they fall plop.
Mm-hmm.
They can't catch their balance. And then one day, all of a sudden, they can. Did the babies learn how to balance themselves, or did the myelin sheath on the nerves grow enough so now there's faster transmission of the reflex? That's what happens. And one day, they're fine. They don't learn it a little bit at a time. One day they can stand, and 2 days later, they're running around bouncing our heads off of furniture. Been there, right?
Mm-hmm.
It's like, it's so fast.
Quick.
It's a reflex. So all those changes we've just talked about with the spine, the curvatures, the hip height, it's all a reflex. So did I tell you A.J. Miller's paper with the reflex? So A.J. Miller has a whole paper on oral and pharyngeal reflexes, where you touch the tongue. If you touch the side of the tongue, it'll make the jaw go backwards. If you touch the tip of the tongue, we have a tip of the tongue reflex called the nursing reflex, causes the tongue to protrude. We have an apnea reflex. We have a jaw jerk. Let your jaw relax. There's a jaw jerk reflex. It'll come down and up just like the patella reflex. So all these reflexes are there. So when you were locked, how long? And you were locked for a long time. So you probably had an open lock because your jaw was shifted way to the side. So what you really had happen was your jaw ended up in front of the eminence, which is why you were shifted to one side. So in order to unlock it, what you have to do is open your mouth wider and then move side to side. But sometimes it hurts so much you can't do that. So you actually can do for an open lock the same thing you do for a closed lock. Did you do the gag?
I tried it with that one guy, and it was a trismus case more.
He was trismus,
Yeah,
yes.
and I that was the
singer guy.
singer.
Right, the
Yep.
singer.
I tried it though. I was
Yeah.
thinking of you. I'm like, I'm gonna try this. He sticks a dental mirror down the throat, and it makes you open like a
So-
snake.
It's a huge gag, and don't warn the patient. The first time you do it, don't warn him. So what happens is, it's a
What does it do?
protective reflex. So pretend you threw up right now, and you can't open your mouth. So all the vomit ends up going into your,
No.
well, it goes up into your nose too.
Yeah.
Your lungs is in your nose, and it's all pretty disgusting. If you do open, If you do open, it comes out your mouth. When we gag, what happens, instead of rotating and translating, instead of this and this, for a second we open like this, like a snake. So the jaw is, when we developed, we go through what's called an amphibian state in development. And the jaw and the ear is the same thing, like a reptile. And then it separates. But for that one moment of time, all the supra and infrahyoid muscles contract.
Wow.
And all 16 of the jaw elevator muscles relax. And so the jaw wants to come straight down, and simultaneously all the posterior cervical muscles contract. So now our head comes up and our jaw goes straight down, and now we just put something in their mouth before we let them close. So
What do you
they
mean put something in their mouth?
Because once they gag, I don't want them to close all the way because I just
Lock up again.
They'll
So
lock
you have
up
to be
again.
very
So it
careful.
could be an aqualizer. Usually I use tongue blades.
Tongue blade. Okay.
And the sooner, the faster you do it, the better.
To block them, and then you try to help manipulate them more so that they're.
A lot of times I have people, you saw some of the videos,
Yeah.
locked for months, and we just gag them and they come unlocked. Other ones, it's a bigger thing. If it's a harder thing to do, then we put in a pivotal appliance. So that's what I did with, what's his name? We got him open wider, but not
Alfonso.
Alfonso.
Oh,
Yeah.
yes.
Did he ever win? No, I didn't get.
I don't
never
think he
saw that.
won.
We will
No.
check.
I think he would have told us if
Yeah.
he won.
I know.
I voted, I had a couple of votes for him.
I
couldn't
did
really
vote
figure it
as
all
well,
out. It was hard.
This was a guy who came in, severely locked jaw. Walked in, he said he had a endodontist, some treatment for like about a month ago. At that time, they did the injection. After that, he could not open his mouth. The opening got shorter and shorter as the week passed by. And the way he came in, he couldn't even talk to me, opening his mouth wider. And he's a singer in the Spanish voice. He's a participant, one of the final participants.
He's in
So he
the
has to go
finals.
for the
Oh, no.
tanner where he has to
Yes.
open his mouth wide and go for the high pitch. He couldn't do that. He came in with some 11 or 12 millimeters of opening.
Yeah.
We did a,
Holy cow.
Yeah.
it was very bad. I did the
trismus,
evaluation,
sometimes
we did that. I spent like 90 minutes with him. We got to 23, I think.
Mhm.
And that was a lot of forward, back, open, whatever. But of course it wasn't staying. And I know that he's going to go back again. So I reached out to her, she saw him, and then we reached out to him. Because he had to leave on
Yeah,
Monday,
it's
and
like,
he
it
had
was
seen me
like
on
a time
Friday.
crunch. I'm like,
So
I
in 3
can't.
days, we had to make sure that
We
he's
got him to
open
like
wide.
35 or something. But it was like, he was, when he left my office, he was in a lot of muscle pain because he really stretched
Yeah.
Yes,
the
yes.
sore muscle.
Yeah.
But he was not, he was out of pain because I talked to him Monday and Tuesday. The pain was all gone. He kept his opening pretty good.
Lateral
But
pterygoid, both the muscles that it was big twitch in the lateral pterygoid, both.
Typically
big
with that
twitch.
though, what you have to do is sprinkle a little essence of time.
Mm.
The problem is
He
he
didn't
was
have
on
that.
he had no time.
Yeah, it was
For
quick. We
trismus-
had to do everything. I know.
Yeah, typically you try not to do it, but I'll put somebody on a tension and leave them for 2
I
or 3
know, he
days.
had
It
to-
increases the blood flow.
Mm-hmm.
But why is it that causes the trismus from the injection? What causes it? Like,
So you go through the filthiest part of the body, the mouth,
Yeah.
Mm-hmm.
and then you take this needle and you go through the tissue, so now it's carrying bacteria with it. And then by accident, so what you try to do with this,
So what we later understood, Ken, about this guy in car, that Dr. Shapira found out that trismus was caused because of the injection that he had during the dental treatment.
so
That
when you
went
go
through the
in, the
muscle
medial
meaning. So
pterygoid
that's what
muscle
we
comes
did.
from here to here.
Yep.
So now we open up and we try to slide in between the back of the jaw and the
Yep.
medial pterygoid. But if you go through the medial pterygoid,
Mhm.
and now you're putting bacteria from the mouth there, and then you hit up against the bone a couple times to make sure you're in the right thing. So now the tip of the needle is bent. Now you pull up and you move to a different spot, and you pull up and move to another spot with this little fish hook on the end of your needle.
Ugh.
And sometimes they're not getting done, so you give them another one and they don't change the needle. So now you're taking that bent fish hook and pushing it in the other way.
So it's just trauma to
And
the
it's
muscle.
trauma and bacteria. A little trauma is good, too much trauma is not good, especially in the presence of infection. Trauma with inflammation, the body heals. Trauma with infection gets in the way of healing.
Yeah. So do you do antibiotics or you?
I usually don't do antibiotics because it's already there. It's already had the reaction.
Yeah.
It's the body's reaction that causes the trismus.
Mm,
So usually you kind of wait it out.
Yeah.
The only reason we did anything with them is because it wasn't a joint lock.
Yeah.
And he had the singing thing, and we had it on some days, so it's like, okay, we're just gonna kind of abuse you a little bit to see where we get your opening.
Yeah.
He could open well enough to sing.
Right,
Yeah.
right.
He could
That's
open
all
well
we
enough to sing. That was our whole goal. If you
Yeah.
ask him now, he's probably back to normal opening.
Yeah.
Is what I'd expect, because he wasn't locked. If you
You're
put
right.
your
Yeah,
fingers,
reach back in.
he didn't
should have it.
deviate, he didn't deflect. If he went forward, he could protrude normally.
Mm-hmm.
When he went right to left,
Yeah,
You can
left
move.
and right. So when left and right, that means there's no disc problem, right?
right. If you have a disc problem here,
Mhm.
and you try to go the opposite direction, it's going to hurt
Right.
because the disc is out here.
Mm-hmm.
It's got that medial anterior displacement, so it hurts.
Mm-hmm.
So
There
you're
was a
going
loud
into the
noise though.
disc
Every
while
time
you
we would move, there was that sound. You could actually hear it, and
Yeah.
that was
Grinding.
Well,
It
the other thing that
sounds-
happens
yeah.
is because he's so tight,
Yeah.
it's squishing, so you have more friction in the joint.
yeah. It was hard case.
The joint,
very hard.
the hard part of the case was timing.
Yep, yep.
It
We were so
was-
crammed, but you're
And
right.
he's probably freaking out and nervous and stressing
Yeah.
out about what's coming. So that on top of
Even
the
my-
other and the
I
root
kept,
canals.
I talked to him a couple times and I gave him breathing exercise. I said, just
Okay.
concentrate, because he was quarantined in his room for 2 weeks
Oh, wow.
in the house.
Before he could go to the
Oh,
thing.
I didn't know.
Yeah.
Okay, okay.
I'm like, calm down, watch these videos. I sent him a bunch of videos to watch.
So anyhow, that's how the whole system works.
Yeah.
So now my part is to bring this together right.
Mhm.
That's the easy part. All we have to do is make lots of little dots and make sure they line up and hit even.
Yeah.
If they have an uneven leg, it's really hard to get their pelvis. Where do you hurt now? Anywhere at all?
Not really. Not really.
So let me show you I'm going to just take a breathe with your chest for a minute. Take a big breath. Does that hurt?
Yep.
So that's from long-term breathing wrong. That's the intercostal muscles.
Yeah.
Do you want to dry needle somebody's intercostals?
Not very much.
It's kind of fun to watch the lung collapse.
Yeah. Not good.
So I'm going to show you a quick spray and stretch. And I'm going to take your mask off. First thing I want you to do is just empty your lungs completely. Blow out, keep blowing, keep blowing, keep blowing out. Don't breathe in, keep blowing out, keep blowing out, keep blowing out. Close together. Expand your chest like you're trying to breathe, but don't open your mouth. Expand your chest. More. Really expand it a lot. Breathe in fast now. Keep breathing in. More. And out. If I press here now, does it still hurt?
Not the same way.
It gives you that sudden expansion,
That hurts.
stretches the inner.
I think you had that thing in your
I had
nose.
a nasal dilator in one.
Oh, when I did that just now?
It's okay.
I'm sorry.
I've been hiding my nasal dilators. That's that.
Okay.
Just
Now,
squeeze the crap out.
sometimes you get people, you have pain in your stenosis.
No.
They're almost always, I always do this.
Mm-hmm.
If they have it, they're almost always sexual abuse. It's usually coming from somebody having an idea on their chest or something.
Oh,
And then they
really?
start, because how often do you see people with a really tender stenosis if they haven't hit a steering wheel?
Yeah, I don't.
You don't. And when we do this, we just check the sternalis, and if they go there, it's like, have you been a subject of abuse recently or in the past?
Hmm.
And then they cry. A piece of Kleenex.
Wow.
And then they tell you, and sometimes you're the first person they ever told.
Yeah.
You see a lot of suicidal patients?
No.
Or at least we don't know.
We don't know. I
Do you
was
ask?
about to say, yeah.
You ever ask them bad patients?
I mean, we had one patient, I
Yes,
think,
sir.
which Kathy is saying,
Yeah.
that he had such a severe ringing and tinnitus for so many years that he have had suicidal thoughts. So,
Okay, so for years I've been going, they say all the TMJ patients, they say half of them are suicidal, they have sexual abuse, they have physical abuse, blah, blah, blah. This is what we used to say. And one of the things I tell my female patients, the big busted ones versus the not big busted ones, when you're going through adolescence, you really are like developer.
Me?
Yeah.
Probably late.
So the late developers, the other girls all have tits, and you don't. So you learn to walk around like this. The early developers
Oh,
learn to
hiding.
walk around like this.
that's a good
It's-
point. Never
It's
thought
a
about it.
very early thing, and it's, when you got big breasts and nobody else does, guess what every single boy in the school is doing? They're snapping your bra straps.
Mhm.
If you have little ones, you put a bra on just because you want to be like the big girls,
Mhm.
even though you don't need one. So
Right.
there's a lot of psychological stuff that's going on.
Yeah.
Mm.
But years ago, I went to a full-day meeting at the Academy of Health. You caught yourself quick. So it's after a while, all of a sudden it becomes automatic.
Yeah.
But you have to train it, and that's why I have people at home slap their wrist. So tell your husband slap your wrist, and then they say I wouldn't tell my husband to slap my wrist. He already beats me up. You get those things too. I never tell my husband. Now you have to have a whole different talk.
Oh boy.
So I went to this meeting, a full day thing on psychology of pain. It's not my thing. I used to be a professor of psychology at the medical school because that was where the sleep department was. But they're talking about suicidal ideation and all this stuff. And I said, you know, I've been doing this for 20 years. Now I've been doing it for 40. I ask every patient if they ever think about it, and they all say no. And these two psychiatrists, I think it was a psychiatrist and a psychologist, said, well, what are you asking them? I said, well, I asked them if you ever thought about suicide. So they just look at me like I'm stupid. And they said, that's the wrong question. I said, Dennis, what do you mean? What should I ask? They said, it's not what you ask, it's what they hear. When you say, have you ever thought about suicide? What they hear is, are you crazy? And they don't want you to think you're crazy. They want you to fix them.
Yeah.
I said, well, what should I ask? And they said, just ask them, when was the last time you thought about suicide? Everybody told me. And why
So it's
didn't
not-
you? What stopped you? Oh, I had a shotgun in my mouth. I was going to crash the oncoming truck or hit the median on the bridge. Why didn't you do it? I was afraid I wouldn't die. I was afraid my kids would walk in the living room and find my blood splattered all over the house. Yeah, it's like, what stopped you? If they say, oh, I could never do it, I want to live, they want to live. If they said something about anybody other than themselves is the reason they didn't kill themselves, they are so at risk.
Yeah.
Crazy at risk. I can't tell you how many dozens of times I'm there with somebody with their mother, their husband, their father, their daughter, and we ask that question, and the mouth of that other person gets dropped because they never knew. They never knew. And it's just the simplest little thing. And so now I always ask it.
When's the last time you thought of?
Oh,
So
I see it
people-
almost every week I get something.
And people don't find offense to it?
No,
like
they just
How
tell
do you
me.
approach that question?
I just ask it.
Just like that?
When's the last time you thought
When was the
of it?
last, the first, I used to ask, are you ever suicidal?
Yeah.
I'll pull out, let me see if I can find my exam form.
I mean,
Well,
sometimes
you
you
work
see
this
the
year with all
consult,
the things going
Usually
on.
do it after consult.
Okay.
Oh,
First visit,
Yeah.
Don't really want to know, right?
usually I've done it
Exactly.
after I've taken away a little pain. I really like to make them trust me.
Yeah.
You have any pain?
No.
You always have pain?
I have had pain, but not anymore, I would say.
When you came in, did you have pain?
There was some, yes.
And
A
you've had
little
pain
some.
for 9 years?
Yes.
And do you have pain now?
No. I'm not feeling anything right now here. Which is, I would say it was more of a, I don't know if I can say pain, but it was that consistent discomfort that I knew it was there.
It was always.
It was always there. So I wouldn't rate it as pain, but yes, that I feel much better.
Have you ever had really bad pain?
Yes.
What's the worst pain you remember? When you were locked?
Yeah. I mean, that was when it was like dislocated. Or something.
Imagine being like that for 6 months or a year. Or imagine if when you were like that, that was your best day for the rest of your life.
Oh, wow.
And everything from that point after will be worse. So I like to, so I don't
Start
sell, I
some-
try not to sell people pain treatment. I am not selling treatments. I'm selling them their disorder and the fact that there's hope. Where's your pain at now?
It's not there right now.
How do you make it hurt?
Actually, the muscles feel better there.
Nice.
It's like when it's balanced, it's better than not working as hard. Is it cured?
Yeah. No.
No, but if you did trigger point injections or dry needling now,
Hmm.
it'd be more effective because it would
Correct.
hold better because you're not going back to the old
But this
pathology
is because of this.
because of this.
The
The
appliance.
appliance, which is why I do what I do,
Mm-hmm.
because the
So-
appliance lets us let the rest of the body heal.
Can you explain what you do? In
So
like,
in the simplest terms,
yes.
Mhm.
here's the head, here's the jaw.
Mhm.
We're going to pretend there's an ideal position for the two.
Mhm.
It could be a little closer or farther apart. We're going to pretend there's an ideal spot. What can be wrong? It can be too close together
Right.
or too far apart.
Or
It can
forward.
be shifted front to back
Right.
or
back.
side to side.
Or turned. Like
It can be
Yeah.
rotated.
Yeah.
It can be torqued. Torqued is if I take this pen, I can bend it.
Mm-hmm.
But if I take this pen and don't bend it, but put pressure on both ends but not enough to bend, it's still torqued.
Mm.
You ever see like nails popping out of drywall?
Mm-hmm.
Okay, so you got two carpenters and they both build a garage. One cuts every piece of wood perfectly, puts one nail in the corner, holds it together, the wood has no torque. The other guy, this 2x4 is a little long, so he pounds it into place and puts 6 nails to hold it. Another one's a little short, so he puts a few nails there to hold it and maybe a screw, and now it goes down. And then they both cover it with plasterboard. And they both look perfect.
Mm.
2 years later, one of them's all twisted and out of shape, and it looks like it's going to fall down, and 10 years later, it's been replaced. And the other one, 100 years later, is still there. The torque is what wrecks things more than anything. When your hips are rotated, that's torque. If the medial pterygoid muscles are tight, that's torque.
Mm.
If you hit on one spot and then when you close, you have to rotate,
That's
that's torque. If you're walking with a long leg and short leg,
mm-hmm.
that's torque on the hips. If it's really a long leg, short leg, you want to put a correction in. If it's not a real one, then you don't. So let's go back to Sherrington now. So we put the equalizer in, the leg length's equalized. So we have two types of disorders we can have. We can have an ascending disorder coming from the feet going up, and we can have a descending disorder coming from the head going down.
Mm-hmm.
But because of the waves, it's really hard to tell them apart. This just lets us differentiate. And if the leg length's equal when we're doing this, then we don't have a structural long leg, short leg. Sometimes you'll get a patient where they even out when they stand, but not when they sit. And because it's really, they have a small pelvic bone when they sit, and now you got to give them a tushy for that.
Mm-hmm.
And we'll do things. And I have a video of one patient I can show you. She came into me, terrible TMJ pain, headache pain, just in misery, older woman. We did a whole bunch of stuff, and we did the equalizer. We had her walk around. We put something under her hip. All the pain's gone. It's fine. Patient from my practice, one of my partner's patients, and then she looks at me and says, that's the same thing you did to me 10 years ago after I had my other hip done. They put her out for surgery. They replaced her hip. They messed up her balance. We got her back to balance. 10 years later, they do the other one. And at the same time, they add insult to injury as they do general anesthetic, so they crank their jaw open wide open. And they rotate their head back so that the anesthesiologist can see.
Yeah.
So I tell 100% of my patients, if you need surgery, just tell me you have horrible TMJ problems and to be very gentle with your jaw.
Yeah.
All you have to do is tell the anesthesiologist that, and
That,
you're more likely to come out in good shape.
Yeah.
Good, good.
All
That's
the
a
time,
good one.
regardless.
That's a really, yeah.
Yeah, so I don't care if they have a bad jaw or not. I tell everybody, you have a problem.
Yeah.
So
Okay.
that's the basic thought pattern of a consult. I'm going
Nice.
to pull out my actual consent, the thing we go through.
You do TMD. By the way, John Kelly is referring patients to you now because he's no longer doing facial pain.
Yeah, I just heard that.
And he's like, I said, who do I send to then? He goes,
'Cause he's just
Ira
doing sleep
Shapira.
pain.
He's doing
He
sleep.
used to send me to sleep before he did sleep.
Yeah. So Kelly's no longer doing facial
Oh,
pain.
really?
Yeah,
He's not doing facial hair?
pain.
Oh, so
So-
it's just all sleep now?
It's all sleep. And he works with Friedman and
What if it's
ENT.
TMD?
He works with Friedman?
Yeah.
Interesting. So
That group.
I'm not a fan of Dr. Friedman, but way back I tried to work with him
I tried to too.
15 years ago.
What
What's
does
that?
with
Masonic
what
Society?
does
Yeah,
Yeah,
ENT.
Illinois Masonic.
Illinois,
And
he did,
I
yeah.
worked with him. I was going to go work in his offices and do the sleep. And I trained all his sleep techs how to adjust for appliances. And we went through this whole thing. And
Yeah.
he's quote unquote very religious Jew.
Yeah.
And he knew my wife was sick with cancer at the time. And he brought me in a few times and I trained the sleep techs how to do everything and how to deal with shit. And then he hired a friend and said, "Oh, my friend's going to do the sleep." And he never even told me. Now, if he would have
Wow.
asked me to come in, I would have done it. I wouldn't have. I would have done it less, but I would have taught him how to do it. So, but he was kind of sneaky. I
Yeah.
taught everybody there. I told him the appliances to do, everything, how to do it. And that's what he did. So, you know the Yiddish word mensch?
Mensch, no.
Okay,
Ooh.
not a mensch. A mensch means, you always
Someone.
have choices. Whatever choice you make, you always know what the right choice is.
Yeah.
Yeah, that was not the right choice.
No.
If he would have come to me and said, can you help me set up my lab, I would have helped him. He was sneaky and kind of, it was like,
And he
was just
didn't
not a
have
mensch.
intentions to.
Would I want a non-mensch to do surgery on me? Now, I've worked with him on patients. In fact, I used to be at the sleep center in Skokie, which closed, and now he owns it. And it was like, he'd call me up and he says, because I sent his patient to somebody else for a follow-up sleep test. And how dare you do that? How dare you send my patient to somebody else? So I went and I met with him. I had sent him back his patients. I had no problem sending him back to his patients, if we were treating him for the sleep test. He's very money-oriented.
Yeah.
After that, I don't. He's not a good person. Even though he's a religious person, he's just not a good person.
Yeah.
Anyhow, so first thing we tell people, everybody, this is the book we use, no magic cures.
Yeah.
Tell them there's no magic cures, and I like to have people walk out of my office with no pain. Do you have any pain?
No.
Do you have any pain? None at all. Where's tightness?
You're in here.
I tell patients
Not have said
that pain comes in different levels. I'm just going to stretch, just gently. Every once in a while, I snap somebody's neck and they end up paraplegic. But they're not my problem because they're no longer a patient. Does it feel less tight?
Yeah.
So, what point does tightness become pain?
When trigger
I'm
points
going
are
to talk
there,
about
or
that.
when trigger points are there?
I think
When
I just
they
stays for a
develop
really
enough.
long time. It was like,
Some of it's how we personally perceive it, because what you call tightness, another patient on a thin edge may call horrifying pain.
Yeah.
Yeah.
We don't know. We're not inside their psyche. The first thing we tell them, there's no magic cures. So since there's no magic cures, what do? We work
Quality
to
of life.
improve the quality of life. So what's the first thing you know about quality of life for a pain patient?
It's
Your
important.
quality of life sucks if you're in a doctor's office.
Yeah.
Is that a good place to spend your life? Now, there is a subsection of patients who have no friends and nobody who talks to them, and their whole life is going to the doctor. And the scariest thing you're going to tell them is you're going to take away their need to go to the doctor. Maybe they have an abusive husband or someone who just doesn't communicate at all, or there's nobody at home, but you're their safe place. Last thing they want to say, they don't want me. Those patients need to have a place to go. The next thing we tell them, 90% of all pain anybody in the world gets is myofascial pain. Every single physical therapist, massage therapist in the world knows this absolutely true.
Yeah.
Every neurologist doesn't believe it a bit.
Yeah.
Not a bit. So the M in myofascial pain is muscle. And the F in myofascial pain is connective tissue.
Yeah.
Easy as can be. So if you eat a piece of steak, the red meat's the muscle, the white stuff is the connective tissue. If a cannibal eats you, the red stuff is your muscle and the white stuff is the connective tissue.
Yeah.
And I do that same conversation because I want them to understand it's them, and then they'll, I'm a vegetarian. Are you a vegetarian? You don't have to worry about eating it. You just have to worry about the cannibals. So, on this page, these are all the symptoms, but I've already gone over their health history before I'm here. On this page, I just tell them to rate their pain, whether it's right side, left side, or both, and date it. I tell them to keep it. Because nobody ever remembers the order things come in. The better, but if you have a 2 on the right and a 5 on the left, usually there's one side that's worse, but sometimes there's not, and it tells you stuff. But I just want them to think about it. I want them to go home after our thing.
Okay.
That's the first time though.
I think it's contagious.
FYI. I
Jenny,
think it's Jenny's fault. I
It's
usually
Jenny's
like
fault.
this.
So
And this is the thinking.
that works great when you're a bronze statue. Never hurts. I've never used that one before. So think there. Okay, the joints. So we talk about joints really brief. First thing we tell them is, they say, I have TMJ. And I said, yeah, everybody has TMJ. In fact, everybody has 2 TMJs unless a surgeon has cut one of them out. If you went to the orthopedic doctor because your knee hurts and he looked at your knee and said, "Huh, you've got knee," how impressed would you be? Ah, you've got shoulder. Crazy, but we call TMJ. Norm, have you all seen these before?
We have
Yes.
this, yeah, in the clinic.
Okay, so when you open and close, you get 2 motions, rotation and translation here. If the bite's in the correct position, everything hits even, and no matter how hard you bite, this stays in the right spot. This is good. I'm going to change the bite. Now you bite, you slid off into the retrodiscal lamina. Now you squish or squeak when you close, but when you open it goes click, because that's the sound of it going back where it belongs. Now you go click, squish, unless you go squish. Now you go, ow, and you can't open it. So what do? If you go to the doctor, they're going to give you muscle relaxers and pain pills. What you got to do is get the mouth open. So if you're locked and you gag them, they open like this. Now you bring them forward and grab the disc back. If we make an appliance, we're making them normal. It's not magic. Be right back.
And now it's past 10, guys. Are you okay?
Jenny, I have to go.
Don't worry, I'm gonna just keep filming. I'm recording
I've been
this. And
taking-
I'll put it on YouTube. You have notes?
Okay. I took notes, and if anyone wants them,
Yes.
I can email.
Email them to me, okay? And I'll put them on the SharePoint,
Have you seen
okay?
this one?
Okay.
Thank you.
Okay.
You have that.
Bye.
You
Have a
say
good
Bye,
one.
goodbye.
sweetie. Thank you. She
But
has
as
to
you-
go right
Bye.
Okay.
Ours is
Nice
broken.
Bye. Thank you, doctor.
Ours is broken, I think, Jenny.
now. Ours is broken.
Yeah.
So now
It's like this.
you can.
Is
It's
yours?
just a-
Yeah, yours broke too. No, this is what we messed with it so much that it.
So now you try to bite, it's going to throw you off depending on where the bite is. So you can change the bite. But as you close, it goes all the way down the whole neck.
Yeah, the effect of it.
I don't remember what was here.
The disc.
No, that's the disc right now. It's there.
It's there. Oh, the little metal post is off, you're saying.
Now my little disc.
Ours
fell.
is like.
You don't have a
This
disc here.
We don't.
Got it, okay.
There is no.
But I mean, you
And I
can
don't think
still
we've ever
talk
seen the
about the
screws.
connection.
You can
Not
talk
even this one.
about,
We have
forward
this, but we
head
don't have those
posture.
multiple attachments.
Yeah,
these are the
Yeah,
muscles.
but-
There's the highway.
Yeah. Yep,
So it
okay.
makes it,
I know this PT. That's Jewel Hissing from Amsterdam.
oh,
I actually bought 2 of them when I went to
oh,
the
that's
clinic.
his thing?
Yeah.
Okay.
They're expensive, those things.
I don't
It's
remember.
like 100 something.
No, it's like, I
Probably
want to say it was
350.
more, it's like 500.
Five
Wow.
hundred.
Yeah.
That's really expensive.
ridiculous.
Okay.
And that's what I was thinking.
So do you know the FS index?
No?
Okay, so it talks about problems that happen. So you start at a young age and they get worse and worse over time.
What does FS stand for?
Kenny, it's, what's the name?
I can't see a thing.
Hang on, what are the things here?
It doesn't say.
It's the doctors.
Oh, it is.
This was
Okay.
Brendan Stack, but it was Kenny Funtz or something.
Gotcha.
Were the authors. I can't see the rest of their names.
Lawrence Font.
Oh, there's Funt.
Oh, Bethesda.
So the problems get worse and worse with time. So I send them home with this book unless I have to go do a hygiene exam, and then I just tell them, find yourself.
Where are you? in
Where are you?
Mm.
And then I tell them, kind of like the story of your life, but sometimes you can go from 0 to 60 in 20 minutes. So you could never have a pain, then you drive dislocate, so you have a baby, get pregnant, they screw up everything.
Yeah.
So I tell them that's the scariest book in the whole the picture in the whole book, because it says if you were here, then you're going to be here, then you're going to be here, then you're going to be here.
You're gonna know where
Life's
you're
going to
be.
suck big time for you. It's a lie.
Mm.
Just like this is a lie, because there's not one joint, there's 2. It's a 3-legged stool. You ever sit on a 3-legged stool where one of the legs wasn't the same length? Do it for 10 minutes, it'll drive you crazy.
Yeah, yeah.
If you go to a bar and do it for 2 hours, you're gonna stretch, you're gonna put one foot on the floor, an arm in here.
Yeah, like
When you get up, you're gonna
everybody-
hurt all over the damn place because you have to correct the
Think about
balance.
2. Yep.
So this is time, and it can be days, weeks, months, years, decades. Angriest patient I ever had had continuous migraine for 50 years. Why was she angry? We got rid of it on our first visit. She was married to a radiologist, and she'd been treated by all his physician friends, and nobody helped. She didn't come in to see me. Her husband had sleep apnea. She made him come in because he had a movement disorder, and she read that not treating the sleep apnea can make it worse. And we made her an appliance, and she's doing this the whole time, and this and this. I said, "Can I have a headache?" She says, "Yeah." I said, "Can I see if I can make it better?" She says, "Sure, you can try." We do a little spray and stretch and put an aqualizer in her mouth, and went on my way. I didn't know she even had migraines.
Wow.
She came back the next time and says, "Okay, I'm glad we got my husband taken care of. I've had a migraine for 50 years and it's now gone. What are we going to do to keep it that way?"
Yeah.
We ended up doing a full mouth reconstruction on her, but it took a long time. We did all sorts of stuff. But that was typical medicine.
So just so you understand, like he will change the bite of a person to fit where it's supposed to be physiologically, right? Like where it's supposed to
So
be.
that would be a more permanent solution then?
Yes. So if you talk, what you hear in all the literature from the orofacial pain people, they say never make permanent changes. You go to tmj.org, never make permanent changes. Well, that means never make anybody well.
Right.
Why are we doing this thing with the aqualizers?
To
From a
change.
physical therapy thing, we want to show that
Balance.
changing the bite
Will
can
change.
change everything. Well, to keep it changed, you have to make it permanent.
Mm.
It's like, that's what we want. That's my goal. I want to say, yes, what happens in the occlusion affects every single part of the body. And if it comes from a dentist, it doesn't mean the same as if it comes from a physical therapist.
Yeah.
You guys are the experts.
Mm-hmm.
Yeah.
So this is not how it really happens, though. Actually, there's good days and bad days, good weeks and bad months.
Right.
There's a flow. So first thing I tell them, this is also a lie. Doesn't have to get worse, but this is the general flow. So remember when you were in 7th grade?
Mm-hmm.
You have a paper you didn't do or a test you didn't study for. What do you do? "Oh, Mom, I got a terrible headache. I can't go to school today." Maybe real, maybe not. You may be stressed from not having it done, and it may be a real headache. It may not be. It doesn't matter. You're Indian. You never did that. You were always ahead of the curve and had everything done ahead of time. I know. So
This is the best I have gotten as an Indian. So.
this is threshold. Threshold is the point where you find it to be a problem. So you can have an underlying problem every day of the week, but until you get stressed out because it's a paper or the test, it doesn't bother you.
Yeah.
Maybe it's not a paper or a test. Maybe you just got a big zit on your face and you're going to be sitting next to that cute boy and you don't want him to see it.
Yeah.
That's all it takes for an adolescent.
Yeah.
It doesn't take much.
Yeah.
A few years pass, now you're in high school or college, and the stuff that was terrible then, you pop an aspirin or whatever, and you keep going, but boy, this is bad. So you raise your threshold. And a little bit later, you have a job or a baby or a husband or God knows what else you have, wife, girlfriend,
Mm-hmm.
and you raise it again. And you just keep raising your threshold.
Yeah.
It's called learning to live with pain. It's a great system. Just raise your threshold. The problem is it takes a whole lot of energy.
Mm-hmm.
I like the term vital energy. I tell people I made it up. But basically, more and more of who and what you are is involved in covering up your pain. So now there's less of you to have friends, for family. Your husband come home from work, and instead of greeting him with open arms and a kiss, you kind of bite his head off.
Mm-hmm.
You yell at the kids.
Mm-hmm.
All the things that people know are happening, and if they're crying, the girls in my office say if they cry, they buy. It's like, I'm not trying to make them cry. I'm just trying to make things real. But
If they cry, they buy.
If they cry, they're going to go through. The case is going to go through. We've made that emotional connection.
Okay, got
and
it,
they now
got it.
believe I have the answer.
Mm-hmm.
Yeah.
Now I have to work 3 times. People who cry, you work harder than anybody to get them well because
Yeah.
you don't want to disappoint them.
Right.
They've been disappointed too many times.
Yeah.
Now, if you start to treat people on this curve, the trick is to treat them on the right day. If you start to treat them on this day when all hell's getting ready to break loose, whether you do the right thing, the wrong thing, or nothing, all hell is going to break loose. Oh, you did that dry needling and every inch of my body has hurt ever since. It was going to happen. You just picked the wrong day to start. If you would have done the same thing 4 days later or 5 days earlier, they would have said, oh, you did that trigger point and my life has changed for the better. And then we think, what did we do wrong? How did we mess up?
Yeah.
There is a natural course to the disease all the time. So what patients need to know, and I tell them this exact picture, that depending on when you start, one guy you think is a maniac and the other guy you think is God's gift. And then so you spend the next 2 years with them, but it was just an accident of which day you saw them 1st. I always tell people we're going to shoot for 50 to 80% improvement. But even with improvement, there's good days and bad days.
Yeah.
And the worst pains are at the peaks.
Yeah, yeah.
These are stress-related disorders. So we have emotional stress. I prefer the term life stress. Money, mortgages, husbands, wives, crazy patients, crazy neighbors, insane bosses. We have all these things. Children. So basically, the expression is shit happens. If you want a stress-free life, find a dark closet, go inside, close the door behind you, and you have no stress. You also have no life. It doesn't work. So we can't fix this. Having said that, this is emotional stress. Pain is felt in the limbic system. That's where we feel emotions. If we are in pain, we don't feel a whole lot of this other good stuff. We only feel the bad stuff. We can have structural stress. Bites, bones, muscles, posture, bad habits, kinky sex, trauma, motor vehicle accidents. We can add, everybody has their own. Some people have accidents after that. You ever have a patient with 2 through 4 accidents?
Yeah.
It's like they must be the worst driver. I had somebody who had like 7, 8 accidents. They were never her fault. She comes and I've had another accident. You know.
Yeah.
A semi came off the top of the bridge and landed on top of her truck.
Oh,
On her front. Now, no matter how bad a driver you are, you can't make it happen.
no.
Sometimes people just have a target that God placed on them. So we have structural stress, and you can include teeth and feet and everything else. We have biochemical stress. Biochemical stress. If you want to have a biochemical stress headache tomorrow morning, have a fifth of gin tonight. It can be allergies, alcohol, it can be hormonal changes. It can be diet, vitamins, minerals, not enough protein. Or just put protein, doesn't matter. Whatever it is, things aren't right. Muscles need calcium and magnesium to contract, but they also need it to relax. If you don't have enough magnesium, you're more likely to have a problem. We live in the Midwest where we have the natural lowest iodine levels of anyone, greater capital of the world, so we have all these subthreshold thyroid patients all over the place. So it's all different things. But we're going to pretend all the stresses are low. Can I pick on you? What's your husband's name?
Sujay.
Sujay. Can I pick on Sujay too?
Oh, sure.
Okay, so your stresses are all low. Life is feeling great. One day you come home from work, you had a great day. 3 people said you're the best thing that ever happened to you in their life. You are just feeling on top of the world, and Sujay comes home and tells you, I don't know how to tell you this, but I've been gambling. You know the kids' college savings and the house and the cars we used to own? We don't. And if he says, that's not even all of it. I've been having an affair.
Oh, God. You chose the wrong person. Now it's stressing me, Jenny. Now it's actually
And your
You
head,
might just
and your head is ready to explode and die.
Can we do it the other way?
I'm
I'm
the
having
other-
an affair and he's. Why not? Put the stress on.
Did she just proposition me? I think so. So on the other hand, he coming back and say, I didn't really have an affair. I just was kind of having thoughts and I'm feeling really guilty about it. And even though I lost all of our money gambling, I just won $200 million in the lotto. And I realize you and the kid, you have one kid?
Yeah, one.
Yeah, you and this little brat are the most important things in life to me. And I'm going to spend the rest of my life making you the happiest person out there. And your stresses go down. And this way you go, my head hurts, my back hurts, my neck hurts because of Sujay. It's Sujay's fault. It's Sujay's fault. That son of a bitch, I'm going to kill him. Sometimes something else happens, though. Oh, maybe we didn't sleep well. Maybe we're worried about something. And all these little stresses build up, and we feel like crap. I don't know why I feel so bad. Nothing happened. Actually, exactly the same thing happened in both times. Our stresses increased past our ability to cope.
Mm-hmm.
One way we had Sujay to buy. The other way was just lots of little shit. Having said that, it's always lots of little shit. We just like to blame someone or something.
For that. Yep,
We
yep.
like to pass blame, but it's always all the different things building up.
Mm-hmm.
Then we go back to this page and said, these are when your stresses are highest.
Mm-hmm.
So now you move on a little bit. We talk about referred pain and then I go through the whole Trebell thing.
Okay. Mm-hmm.
I ask if they have kids.
Mm-hmm.
How old is your little one?
9.
9.
Mhm.
First thing I'm going to do is I'm going to say, oh, you got a 9-year-old. Do they have dark circles under their eyes like you do? And you go, yes. I'm going to say, that's a doctor in the city you need to take them to. I'm going to send you to see Kevin Boyd. He and I may be doing a research project looking at the parents and kids.
Oh.
I think I'm his best referring doctor because every patient I come in, I said, oh, do you have kids or grandkids?
You should see him.
What?
You tell him you should go see him.
I tell him, go see Kevin. He's great. He's fantastic.
Yeah.
And he can prevent all this stuff. Ideally, my assistant who lives in Wisconsin wanted me to treat the little ones.
I'm taking my daughter to John Kelly right now.
John works with Kevin. Kevin's the best, so I just send everybody to Kevin.
Okay.
But that's John Kelly. You want to grow them early.
Yeah.
How soon? My assistant took her 3-year-old to see. She lives in Wisconsin.
Mm-hmm.
She drove
To
all the
see-
way into
to
the
see
city to
Kevin.
see Kevin, and it's already done it. And she's already got her 2-year-old who's been there 6 months ago.
Yeah. Yeah.
So it's like, how soon is too soon? Well, let's see. When does the brain develop its most? Let's do it then.
Mm-hmm.
I got involved in this because I had a 5-year-old son with sleep apnea. Nobody would listen to me. And for 2 years, I fought with doctors, and nobody would listen to me. At 5 years old, we live in Highland Park, so they check the kids to see if they're ready for school. And they say, your kid has ADD, ADHD, and we're going to put him on Ritalin for the rest of his life. Yeah, right. I'm going to let you do that to my kid. Took him to Rush, had a sleep test. First thing they said, well, it's $6,000 and your insurance won't pay for it. I never asked. Said, let's do the sleep test. We go in, we do the sleep test. I spent the night talking to a postdoc fellow all night long because my son's doing the sleep test and I'm not leaving him there alone. Turned out he had an apnea index of 60. We took out his tonsils and adenoids. We orthopedically grew his mouth. We got a tongue tie and a lip tie.
Mm-hmm.
And a short, fat, kind of difficult kid to be around. Happy, but difficult.
Yeah.
Immediately went from a 50% growth curve to a 90% growth curve. He graduated college, double major, double minor, magna cum laude. Turned out his drug of choice wasn't Ritalin, it was oxygen.
Mm-hmm.
He needed to
To breathe.
breathe. Period.
Yeah.
So, we talk about referred
Right.
pain, then
Yep.
we talk about pain.
Mm-hmm.
First off, you know what? Men don't like to be around women in pain. In fact, they have a 5-letter word that starts with a B that they use to describe them.
B-I-T-C-H.
B-I-T-C-H. Because if you're in pain,
You're no
what's your
fun.
husband's name?
Michael.
When Michael comes home, if you've been hurting really bad all day, you give him, put your arms around him,
No.
kiss him, and take him to the bedroom?
No.
You're lucky if you don't bite his head off. Take the kid.
Yeah.
Take the kid is
Yeah.
usually the first thing out of your mouth. So you get stressed. Because you get stressed, you tighten your muscles, more pain, more spasm, more tension. You end up on the merry-go-round.
Yeah.
Sometimes you know why you're on the merry-go-round, sometimes you don't. When you know why you're on the merry-go-round, it's easy. It's sleepers still. When you don't, it's lots of little things. But having
Oh,
said
that's
that, it's always lots of little things. When you're on the merry-go-round, those are your peaks.
Yep.
Down here is sleep. When you're stressed out, how well do you sleep?
You
You don't. If you don't sleep well, you get more stressed. If you're in pain, how well do you sleep? You don't. If you don't sleep well, your pain gets worse. So there's all these little merry-go-rounds. If you have a lot of spasm, how well do you sleep? You don't. If you don't sleep well, you get more spasm. Down here is big old depression. If you're in pain, it leads to depression. If you're depressed, your pain gets worse. If you get spasm, it leads to depression. If it doesn't get better, it gets worse. Tension, same thing, and sleep and depression are related. It's like the expression used to be, stop the world, I want to get off. That's what everybody wants. They do not want to be on this crazy nuts and merry-go-round. You know what a psychosomatic illness is?
Mm-hmm.
So with your pain, is it a psychosomatic illness?
No.
Okay, so if you had pain,
Yeah.
if you had a psychosomatic illness, what it would be means in English, not doctor, I hurt because I'm crazy.
Mm-hmm.
Are you crazy?
No.
Good.
At least I
Glad
don't
to hear
think-
it. We can work together. Same two words in a slightly different order
Mhm.
is somatopsychic. That means in English, not doctor, my pain is making me crazy.
Yeah.
If you hurt all the time and you don't get depressed, you're a certifiable nutcase. If I took a big sharp Bowie knife, shoved it in your side and started twisting, how long till you get depressed? About a second, maybe 2. Pain is a normal response to depression. Depression is a normal
Yeah,
response to chronic pain.
Yeah. Yeah.
So, I mean, this is explained to everybody.
Yeah.
And if I haven't already asked them about suicidal things, we talk about it now.
Yeah.
A lot of times
Okay.
that's when they cry because it's not their fault.
Mhm.
And then I always ask them, always, if you ever had a doctor who treated you like you were crazy. Oh, yeah.
A lot of
Women
them.
especially. I said, was he a psychiatrist? And they say no. And I said, if a doctor treats you like you're crazy and doesn't believe you really have pain, it's a bad doctor and you want to change doctors.
Yeah.
I tell them every single one because they make them worse.
Yeah.
When they act like they don't believe them, that they're a pain, they make those patients worse.
Yeah.
The system has totally failed them.
Right. Right.
You know who Hans Selye is?
No.
In 1950, Hans Selye, the same year I was born, Hans Selye wrote a book, The Stress of Life. What I call pain in my little diagrams, he called alarm. What I called threshold, he called resistance.
Mm.
So we're covering up. And then he talked about exhaustion. If you're living your life up here, barely keeping things under control, now you've got a cold or a flu, or you miss a couple nights sleep, you feel like you got hit by a train or a Mack truck. You have nothing in reserve. And so what happens is something pushes them over the edge. Oh, maybe it's a spouse that died, or their husband had a heart attack, or somebody had a stroke, and everything in life changed, and they have nothing left. They've already put it out. A lot of the patients we see, not almost all, a lot of them, they're the caretaker for the whole family. They're taking care of the husband, the mother, the father, the brother, the sister, blah, blah, blah. But there's nobody left to take care of them. And they just hit their breaking point.
Mhm.
So we need to do a diagnosis. First thing we do, I talk to you.
Mm-hmm.
I said, I usually know within about 2-3 minutes what's going on. Before Mass, I'd watch how people swallow, and you see all the deviant swallows. You see the dark circles of breathing. You see the tips, the heads, the forward head posture, the breathing here and not here. It's obvious. We see it. We're trained to look for it. So I tell them, yeah, the first 5 minutes, I kind of figure out what's going on, and now I have to explain it to you in terms you understand to make it real. I tell them I used to poke and prod and find all the spots that hurt, and then I'd send you home to come back, and you'd go home feeling 10 times worse. You wouldn't want me to do that today, would you?
No.
Nobody ever says yes. I said, we're going to need x-rays, we need models, we're going to use a low-frequency TENS to relax your muscles. That's right. We're going to analyze how your jaw movements. We can measure your muscle activity and joint sounds. I usually don't bother because it costs a lot of extra money, takes a lot more time, and I'd rather spend my time making you better. But if you really want all the extra bells and whistles, we can do it. It's just going to cost you a whole lot more money. Want to spend a lot more money?
No.
Nobody wants to spend a lot more
Nobody.
money. No matter what we charge them, everybody thinks it's too much.
Yeah.
We show them the picture with the TENS. What's it feel like? This is a jaw tracker. We put a little magnet, attaches to their jaw, and we can measure 3-dimensional how fast it's going, right, left, forward, back,
Oh,
where
wow.
it's at.
Okay.
That's all it does. It just measures the position of the magnet in space. If this is the jaw, actually you need 2 pens to be the jaw because of 2 joints, and this is the magnet. As the jaw moves, we track the magnet, not the jaw. But
Magnet.
if the magnet does this, the same thing's happening here, here, and here to a smaller degree. But it doesn't mean if it goes this way, we typically think, oh, the jaw's went to the side. Well, it is possible it did this, but it's quite unlikely. So we infer what's happening here, but we actually measure just at the magnet point. And it gives us tracking on a computer. We can record sounds. I usually don't. We give them lots of questions to go through. Then we talk about treatment. What do we do? It's really simple. Part 1, get rid of the pain and the muscle spasm. Do I want to do dental work, reconstruction, lots of things that I can't undo before that.
No.
Get them comfortable. Stabilize the bite where they're comfortable.
Mm-hmm. Through appliance.
When do we go to physical therapists? Well, once they have an appliance and they stabilize bite, they still, the rest of the body is a mess, you got to get it fixed.
Yeah.
Sometimes they're coming to me from the physical therapist because they won't stay stable.
Mm-hmm.
Mm-hmm.
I get them from massage therapists. I get them from chiropractors. I get them from lots of doctors.
Yeah.
Once you get comfortable, now you have to figure, what are we going to do long term? You see a lot of people who come in with full mouth reconstructions and pain.
Yeah. They didn't do all this.
They
didn't
went
balance
it
the
totally
body.
ass backwards.
And I've talked to a lot of reconstructive dentists, and it's like,
They don't
They don't-
understand the head's connected to the rest of the
yeah,
body.
but they also, I think, have a hard time working with someone else and waiting and trying to
It's
deal with.
about money. I'm old. My kids are grown up. My house is paid for. If I decided I'm ready to retire tomorrow, I'd close the doors and not worry about it. If you're hungry and really want the money and you have $250,000 in debt and you're
Yeah,
up
then
to your
you're
ears,
trying to
you're trying
build.
to build.
Yeah.
So what can we do? Sometimes we can grind down teeth. Not very often. We can make removable overlay partials like the gold one I showed you.
Mm-hmm.
We can do reconstruction.
Yeah.
Sometimes there's somebody who can't afford that. We can take their lower plastic appliance, one tooth at a time, build composites on the teeth to exactly the same spot, do a few more adjustments, and they got a long-term temporary solution.
Yeah.
Mm-hmm.
They need something else done. But it's better than nothing.
It's better.
Stable. Sometimes we can do orthodontics, not
Mhm.
very often anymore. You can always do surgery. I love the quote, there is no disease or disorder known to mankind that can't be made worse by sticking a knife in it. Doesn't mean don't do surgery, but if you're going to do surgery, be really sure you want to do it.
Yeah.
Right.
And when's the best time to see the physical therapist? Before surgery.
Before
Why don't all surgeons
Send
send
them.
patients first? It's real simple. If you fix them, they're not going to get to do their surgery.
Right.
What do surgeons want to do? Cut.
Right away. Mm-hmm.
So they do the worst thing they possibly could for the patient.
I know.
So when you get a doctor who sends them before surgery,
Harvey is sending me patients now. Alan Harvey and he's I want to say Winnetka now.
first thing you tell them is,
Oral
oh my
surgery.
God, you have such a good doctor. He wants you to do the physical therapy before. He's willing to sacrifice possible future income because he cares more about you than making money. And you just keep telling those patients that, and you know what they're going to do? They're going to tell him,
Yeah.
You're a good doctor. She thinks you're great. You care more about me than you do about just making money. What kind of reputation does that build?
Right
You're
one.
the good doctor.
Yeah.
So then we have the DNA appliance.
DNA.
The DNA, the RNA appliance, we can grow bigger airways, bigger jaws. What
Is
is
that similar to an L? Because I was gonna ask you about
No.
people with like really narrow palates.
I don't like the ALF. I do the ALF. I got some ALF samples I can show you, but I don't really like
This is more forceful than the elf.
More. Is that the
Forceful.
one
This
where
is you turn the key
okay.
and you wear it a lot longer. It's like a big appliance that you wear
Is
for
that
the
one
majority of the
that,
day outside of work, right? Like you can pick it up for work
Mhm.
and then you
who
wear
was
it the
one
rest
who
of the time.
had that?
Judith
The Taiwanese lady.
Danaher.
Oh,
She's seen me
yes.
before COVID. She was coming in. Judith Danaher.
I know who she is, yes.
Yeah.
She's got some cosmetic concerns.
Yeah.
And widening. I don't
She
think she's
was
widening right now. I'm trying to remember what else.
I don't think she's quite done.
She's not done.
And I don't know if she's continuing.
Look, I'm not sure she's continuing either. Sometimes people have this idea in their head where they're going to end up, and it's like she's not done, and you can correct everything. But I think she was concerned about evenness and stuff, and
Yeah.
it's like that's not what this appliance does. That comes next.
Yeah.
I think she told me that you said, "Oh, you got such a big mouth," and because I think you said something to her how wide it is.
Yeah, she is wider. It's a
Mhm.
lot wider.
We're real good at growing bigger airways that makes everything better.
Does it ever narrow back? Like, does it ever collapse back?
That's
they
why you
train
do oral myofunctional
myofunctional
therapy.
therapy.
The best retainer
It's a
Is it
tongue.
is the tongue.
And the lips.
If they swallow right all the time, guess what does the final reshaping of the arch? A lot of people don't need ortho after growing bigger because the tongue's there. And now just makes it shape and match the tongue. I've had people who've lost half their tongue. Their face is collapsed because there's no tongue to push the teeth out and everything starts to collapse inward.
What about people with macroglosia then? Because you can only grow that.
So most of those people have bad deviant swallows. The tongue is being used the wrong way.
Mm-hmm.
The hyoid bone is going up. And what you see in the mouth is normally 20% of the tongue and 80% of the tongue is down here. These people, the tongue is way up high, so it looks big. It's not a big tongue macroglossia disorder.
So you have to pull the hyoid down?
You have to bring there. As soon as, like, you always will see the big tongue on people, here. As you straighten the head out, it goes away.
So it's more like postural.
It's postural, it's tongue. If you have a narrow mouth, where are you going to put the tongue?
Down.
Down or up. If it goes up, it looks huge compared to the tongue. And these are the people who gag when dentists work on them. They can't stand them. Why do they gag? Because they got a compromised airway, and now you stick 2 hands or 3 hands in their mouth and a mirror and a drill and start spraying water, and they're going to drown. And they're anxious and they're phobic. Well, you know what? They're protecting their airway. If somebody's trying to kill you by suffocating, you're going to be a little nervous. You're going to be pure sympathetic.
Yeah.
Pretend you're out in the middle of Lake Michigan. You fell off the boat. You can't swim. You see the boat going away, and you're trying to keep your head above water. Think you're in your sympathetic mode?
Oh, yeah.
A little stressed?
Heard of it.
Have you seen this book?
No.
No.
Okay, I have to remember to bring another one in. This is a present.
Oh.
This book came way out originally in 1967.
Wow.
So this is not new.
Okay.
The first person who really coined the term oral myofunctional therapy was a guy named Jim Gary.
Gary, yeah.
He invented the term. He was also the guy who invented the Nook. Except the Nook was not a pacifier. It was an exerciser, like a myomunchie.
Mm-hmm.
It was designed to grow a bigger mouth. He sold it to Playtex, who turned it into a pacifier, and he said that was the biggest mistake of his life.
Wow.
But it also made him rich.
Yeah.
These are kids with airway problems. The allergic salute, you know this one.
Mm-hmm.
Fidgety as hell. These are the 88 kids. All these kids have shoulders out of focus when you look at it. They have kind of sad-looking faces, reverse smiles, dark circles under their eyes. Sometimes you'll see the crease from the salute.
Yeah.
Stop and do it as you go.
Yeah, what's the name
That's
of
the
that?
allergic salute. These are some of the patients, the sad face. All of these kids don't look right. Dark circles. If you look at their shoulders are out of focus on everything. They all have terrible forward postures. What does that mean? All the curvatures in their entire spine are wrong.
Yeah.
Some of them are mouth breathers.
Yeah.
Now they get gum issues and decay issues.
How do you relate the dark circles? You said that a few times, but how does that relate with the
Okay, if somebody's cyanotic, what do they have? Blood without enough oxygen.
Okay.
It's a backup. It's a sore backup in your face.
But Indians tend to have a
A
darker.
lot is what I've noticed, and that's why I'm asking.
Am I saying it wrong?
So my friend Raj has started a whole huge group in India. This is what they're doing, is they're growing bigger airways and taking care of these jaw problems.
Oh, okay.
And they are
Because my mom
amazing.
has it, I have it, my sister has it, so it's almost like
So it's not genetic then?
It's
The darker.
epigenetic. So you know what the difference between genotype and phenotype is?
When I was in high school.
So we have chromosomes, and on the chromosomes we have our genes. The genes make up a very small part of the entire DNA molecule. So they identified all these genes that have different specific traits. A genotype, that's your hardwired gene.
Okay.
If you have a computer, this is a Mac Air, whatever model. The phenotype is the result of the software programming. Can you put all sorts of different programs on?
Yeah.
Sure. You can do YouTube and Facebook. You can watch porn. You can watch myotherapy things all over the place. I send people and say, start here. Watch some videos, and then later on you can go to somebody if you don't want to go. So these are kids. The dark circles is blood without enough oxygen. If somebody's cyanotic all over the place, you worry about it. They're only cyanotic under their eyes. But if they've got dark circles, it means they have bad drainage. So they're more likely to have sinus problems. Sometimes they have jaws that are back, narrow mouths. Even before teeth, the baby doesn't have enough room for their mouth.
And the tongue sticks out.
Mouth breather, the little lips here, the muscles stick up. Back up, sinus infections, everything else. You end up with the teeth in the wrong spot. The teeth end up in the balance of forces of muscles. Tongues, lips, these are all Dr. Gary's pictures.
Mm-hmm.
This book was 67. My son was born in 1980.
Wow.
13 years after, and in
Wow.
85 is when we got him done, but
You didn't see that then.
I knew it, I just didn't know it as bad. The
Yeah.
reason I got my son treated at 5, and I thought I was brilliant. I thought I did the best job.
Mm-hmm.
I fucked up big time because I should have had it done 2 years earlier.
Yeah.
The difference in brain development between 3 and 5, sleeping well and breathing well, is huge.
Yeah.
So it affects the throat, the tonsils, the eyes, the tongue.
Oh, that's really scary. Mm.
If your mouth is narrow, if the roof of the mouth is narrow, the floor of the nose is narrow because it's the same bone.
Yeah.
Teeth are too far out, not enough room, jaws too far back. This kid's not a thumb sucker. He's propping his mouth open so he can breathe. His thumb is an airway. You take the thumb away, he's still doing it.
Yeah.
Mouth breather, dark circles. This guy looks like he'd stab you in a dark alley.
Mm-hmm.
But allergic edema around the eyes, terrible forward head posture, overclosed on the jaw. He's got a rotation and a tip. People will tip and rotate to the side where they get a headache.
Mm-hmm.
Why? If I squeeze there, it hurts.
Mm-hmm.
If you do this, it feels better.
Right.
If you do this, it feels worse. So
You're going to go 10.
makes you better.
Yeah.
Do they know they're doing this?
No.
No.
They don't know.
I walk around an airport zone. I go, oh, is the pain in your left temple really bad?
Mm-hmm.
How did you know that? It's like, and I would tell about 90-95% of the time I'm right. It's like, I see people, I can't help but look. That's what I do all day long. Is I sit and talk to people,
Yeah.
and I try to not ask the questions. I like to see it, touch them, and show them. Eustachian tube dysfunction. One of the jaw muscles is the tensor palatini.
Mm-hmm.
One end of it brings a soft palate, the other opens and closes the eustachian tube, stuffy ears. What happens if you can't hear as well through one ear as the other? You turn your good ear. I sometimes have people put cotton in their good ear so they're not turning their head to give them the bad ear.
Oh, wow.
You know Dr. Getzell?
Yep. Yep.
Same thing, input, output. If they're tipping their head because of not being able to see, he can put lenses and straighten them out. It's like, can I do that with teeth? Sometimes it'll happen, but you know what? If he gets it corrected, most of the time after we finish them out, they don't need the lenses anymore.
Yeah.
But they need it.
For that
I had
one.
people who couldn't walk in my office if he didn't have them in lenses first. They couldn't move. So that,
Can you sign it real quick?
it's not mine.
But just sign it.
Okay.
So fine.
Thank you.
My stomach is talking to me. Let me do something. Can you live close
Yes,
to
I will.
Lakeview, right? Close to me. Yeah. Okay.
Thank you.
Okay, so I buy these books every time I go on to Amazon, and if they're for sale,
You'll go.
if they're cheap, I buy a bunch of them. I have another one sitting at home, and I'll bring that one in to take the place of this one. I give them to teachers all the time.
Yeah.
First, second, third grade teachers, because now they can recognize this in their kids, and if they
Right.
catch it early, you can change their lives. Have you seen this flow chart? This is Dr. Gary's flow chart, all the way through. So, we were talking about genes and phenomes and how does it happen. So we have the genes, and we have a genotype, and you can get that measured. The phenotype is how those genes are expressed
It's a physical.
as a physical appearance. So do you know who Harvold is? Harvold did work on monkeys. He'd put in artificial plugs in their tongues or artificial tonsils. And these monkeys would look more like kids with allergies than the kids that allergies look like normal kids. It would change how they swallow, cause open bites, cross bites, smaller lungs and shorter legs on the side of the airway obstruction. Now, in my gut feeling, the shorter legs were really a functional change. And if I could stick an aqualizer in, I think I could have corrected them. But it's how the genes are expressed. So a phenotype has a lot to do with the environmental effects on the body. And that's what we used to think completely, except now we also know one other thing goes on. We can have epigenetic inheritance. So when you were born with all your eggs already in your ovaries. When your mother was born, she was born with all her eggs, including the one that made you, in her ovaries. So her mother epigenetic state will pass on all the way down to you.
Her mom.
Her mom. So it's not the same as genetic. Genetic changes take thousands of years. But epigenetic is all the space on the genes between. And now they know that you can have epigenetic inheritance, which is a project I'm going to be doing with Kevin Boyd. And I called up my daughter because she's a genetic counselor at UCLA, and hopefully she'll help. I haven't heard back from her yet. Actually, I sent her an email. So she did, I lost my wife to breast ovarian cancer. She had a gene called the BRCA gene. It was a gene for breast and ovarian cancer. That's what it causes. And my daughter carried the same gene. So she's already had a double mastectomy. She's already had her ovaries out. She doesn't want to pass it to another generation because her grandmother died of complications of breast cancer, and so did her great-grandmother. And she lost her mother. She doesn't want to pass it on. She was a theater major. She worked for Google, did all sorts of stuff. After that happened, she went to Johns Hopkins, did a fellowship at NIH. And now she's a genetic counselor. Changed everything. Well, funny thing about genes, back in the Middle Ages, the gene that caused breast and ovarian cancer, in those days the average life expectancy was 35, 40 years old, especially women because they died during childbirth a lot. People who had that gene didn't die of the plague. The Black Plague that wiped out more than half of all the people in Europe, if you had that gene, you survived, which meant you could now pass it on. And it turned out to be Ashkenazi Jews, Spanish Jews who had the gene. And so they can actually go back and look where they expanded and spread through the environment, through the population. So starting in babies, did you all train with Joy Muller?
Yes, I did.
You did.
And I've trained all of them.
And you've trained them, okay. So we all know it's important to breastfeed. How long did you breastfeed?
9 months.
6 months.
Okay, so we know ideally it's 2 years.
Yeah.
But it's hard when you have a life.
Yeah.
So I never criticize. I tell everybody no guilt. However, when you're not breastfeeding, you usually end up with formula. Formula happens to be the perfect food because it's made from cow's milk. If you happen to be a baby cow. If you happen to be a baby human, it causes allergies. We get chemical mediators that change. Now, is it all because of this? No, we live in a polluted world. They've actually shown changes in utero before the baby ever gets done. It's the plastics, it's the hydrocarbons, all these things. But we get allergic edema of the nose. When this happens in infants, it changes the cells. So we have 2 types of cells, basically. One that makes mucus and one that makes serous. With allergies, you make more mucus and less serous. Now, we also have little cells that have cilia that move the crud out. Except if you get too much mucus, little cilia get stuck in the muck. Everything sticks, and now you get more infection. You get lowered resistance to infection. You don't smell your food as well. You get poor eating habits because we got 1 billion years or whatever of evolution telling us what to eat and not to eat based on smell. So you get nutritional depletion or weight gain. Opposite sides of the same coin. So you can have 2 people who don't smell food well, and one gets fat and one gets scrawny. My great uncle was the first man to isolate vitamin B6. Smart guy. He was at Northwestern. He couldn't get tenure because their quota of Jews was filled. So he ended up at Berkeley in Southern California, which was a good thing. But his last 20 years of life, he also was one of the chief people developing C and K rations they put to the soldiers. Biochemist, nutritionist, hard science. Last 20 years of research was that you couldn't get the proper nutritional value out of your food without gustatory enjoyment.
Wow.
That the savoring and enjoying the food was an essential part of the nutritional process. We now know that there's taste buds all the way through the gut, not just in the mouth. But smell is huge to taste. If we don't eat right, we have less resistance. Now, go to France. They eat high-fat meals, and they're skinny.
Mm-hmm.
You come here, we eat high carb, low fat, high fat, low protein. We do every kind of diet. We eat McDonald's, and we're fat. What do we eat? We eat fast. We don't savor. We don't enjoy. You go to France, they have 2 3-hour meetings. We have 2 and 3 sittings a night at a restaurant. They have 1.
Mm-hmm.
It's an experience that you do. So it's not just what you eat, it's how you eat it. Venous puddling under the eyes. You get stuffiness, you get stagnation, you get a lower oxygen balance, changes your acid-base balance of your body. It interferes with the proper growth from the hormones and things. So all the chemical systems in our body work in narrow pH ranges, so it changes them. So all this changes, and then we come to the next thing. You get adenoid tissues blocking. Adenoid tissue blocking leads to eustachian tube blocking. So now you can't hear well. So now you go into bruxism. Kids will start to brux movements even before they have teeth, though. It doesn't mean they're grinding their teeth. They're moving the jaw around to open up their ears. And now, when the teeth come in, they get a shorter jaw because of it. My wife was, Dr. Freud was supposed to be here, and he was going to adjust my wife. Let me put my phone.
I know
It's
it's
11.
late. Yeah, we need to go soon.
Yeah, we should.
Okay, we'll try to finish up. I'll try to go quick.
Yeah.
But this is important. To
No, I get it.
So, tonsil and adenoid problems, responsive turbinates, nasopharyngeal airway obstruction. Common thing. All this leads to that. It can cause more sinusitis, headaches, jaw pain, maxillary jaw pain, leads to mouth breathing, tongue's in the wrong position, imbalance of the teeth and tongue, changes the shape of the mouth, malocclusion, up, too big, too right, left, forward, back, twisted, everything. You're more likely to get middle ear infections with a small airway. You get less oxygen saturation, less exercise tolerance. You get ADD, ADHD, dyslexia, opposition defiant disorder. I call it the bad parenting disease. But you get collapse of the arches. Everything we've talked about today has to do with that lung. This is kids. So I sent void. This is adults. What happens in the adults? We have a high balls, less room for your tongue, less room in your nose, poor tongue repose, facial grimace when swallowing. And then this weird thing happens. On this side, 80% of the people are female. And they get headaches, neck pain, facial pain, sinus pain, migraines, myofascial pain and dysfunction, fibromyalgia, eye pain, neck pain, back pain, 80% female. And of course, TMJ disorders. TMJD, we'll put more TMD. This side, it's 80% men. And they get snoring and apnea, obstructive apnea, dysphagia, and GERD, or gastric reflux. But they have exactly the same structural problem. They actually have the same problems with function, but there are estrogen receptors in the TM joint. So women have fluctuating hormones. They have fluctuating hormones.
I didn't know that. Our patient, she went into that estrogen replacement therapy, and that's when that started with her jaw. Laura.
So when women become postmenopausal, a lot of problems get better, but then they start to get more snoring and apnea and things like that. So you give them estrogen replacement therapy or estrogen, and it goes the other way. But it's all the same. A guy named Shimshak did some studies in 1998. And what those studies said was people who have TMJ disorders, the second one said they have a 300% increase in use of medical insurance in every single field of medicine except obstetrics. Every single field of medicine. Why is that?
Because it's leading to...
The whole system is broken. Exactly. It's wrong. And what was the response of Blue Cross Blue Shield of Pennsylvania, whose records it was based on? Oh, they made Dr. Shimshak destroy his original data because they didn't want it out there because they don't want to pay for it. So these are all the references for, and then we'll just do a quick scan. couple things. So this is a lecture I gave at the anti-aging medicine in 1998. So this is not new. Everything I told you, there's
I
not
know,
one
not-
new thing since I did this lecture in 1998. It's all old. This is my article on sphenopalatine ganglions. It's actually, if you go to my spgblocks.com and you go to the third page of the blog, this
Yeah.
is just printed off of that page.
Okay.
So you can all find it someplace.
Yeah.
Talks about all the stuff we just talked about. This was TMJ has a co-conspirator poor sleep. When Cranio changed the name of the journal from Craniomandibular Practice to Craniomandibular and Sleep, because I was the quack doing sleep for 30 years, I got to write the editorial. That and $3 will buy you a cup of coffee at Starbucks. So
Awesome.
this is a very cool thing at the National Heart, Lung, and Blood Institute talking about TMJ being cause of things like sleep apnea and snoring. They may have gotten the cause and effect wrong. But what their study actually says is the cardiovascular and sleep-related consequences of TMD disorders. I'm just going to
Okay.
give you this,
Thank
this,
you very much.
and this, and we're going to do a quick scan
Okay.
just to see what you got.
All right.
Okay, so this is worthwhile. I know we talked about a little more.
It's amazing.
This was
No.
great. This was great.
Okay.
I'm gonna put this on YouTube and send you the link, okay? Not that I'll share it.
Far away from here, because the phone and stuff isn't good for the computer. So yeah, I'll put it on the
Oh,
desk.
not there, over here?
Yeah, that's where we're gonna go.
You can take it off. I think it's been like.
Well,
No, I'm
yeah,
gonna show you the scan.
Oh, no, her tens can be gone.
We're
So
gonna-
on the 10th.
I'm gonna do it when we do the scan.
Oh.
It helps us do what we do. Let's see.
This is the.
Yeah. Happening. How much is this?
3,900.
Is this the one that, the one that, you had told me about this group?
This is the one, but I buy more, I've bought more of these than anybody else on the planet. And I'm not, I can't tell you the price, but I buy a bunch at a time, and if
Yeah.
you want one,
900.
I get you one for a whole lot less.
Okay, so but what, I can't have people stay for like that long.
Actually, have them come 45 minutes early and put them on it while they're waiting. Charge them for the attended times, because you're gonna check them out afterwards. And then do that, whatever you normally do. Of course, then you're gonna have to pay more taxes.
For what?
Because you're gonna pay more money.
To pay more.
It's intended for 45 minutes on top of that.
Well, it's, oh yeah,
It's
attended
just the
time code.
Yes, you're looking
No,
at
where's the
it.
Kathy's?
We have to ask Angela like how much we get for that time.
It won't be that much for 10 things. All those are little tiny things. But like my brain is so off since I work with Pro. It's like I hit even, but I hit in a couple spots. I'm not like I'm hitting even. But I feel like I hit
Can
only
you expand your
I expanded it, but not enough. The elf doesn't do enough, I think.
No, I'll sometimes use an elf place to use it is to round off an arch after I grow it bigger.
Yeah.
Well, 10 years ago, I would have told you it's impossible to grow it bigger. That was a really hard thing. I listened to Dr. Sidney talk a few times. I kind of went over my head because I said, well, that's impossible.
Yeah.
I also used to think it was impossible to change the cans of the maxilla.
Yeah.
Well, neither one of those things are possible anymore.
And the appliance.
Actually, I'm gonna let you take it off. Do you have the package for it still? Here we go. Put it on here for now. Well, things are expensive.
I didn't have my breakfast.
Actually, I bought it though. Coffee shop, there's a coffee shop.
Oh, you did?
Here. Yeah.
Did you have my
Switch over to here.
That's still adhesive.
So the piece of, yep. Same stuff you do, give them this.
Yeah.
Mhm.
Oh, like that stuff we put here,
Mm-hmm.
you put it on the magnet.
Okay.
Hold on.
To hold this together.
Thank
I know.
You know, my
you.
patients
Have you
don't like-
tried it?
I have.
Some like it, some
Exactly.
totally hate it.
Because
You
it
gotta
doesn't
try
really
it.
stick properly. I like the pink one now than the brown. The
Is
pink
it
one
pink
that comes, there is a pink one that comes in the night.
Let me
That's not
see
for
the
that.
What's that for?
That's, that you put in front of the mouth.
Mhm.
And then you put the tongue on the elastic is in the tongue. It's just to stress the vestibule.
We don't use it. We have never used it.
Because that doesn't go away, it doesn't dissolve. Don't use it
You have
dissolve.
to show me how to use that.
You just put it in front of the teeth,
Just goes inside your mouth.
like this, right on top, like flat
Oh,
and around the lip.
okay. And the adhesive is only brown, not pink. Oh my God, one of the best.
One's like a gummy kind of, like the stone
Yes, yes,
adhesive
yes.
that's in like the little tube,
You,
and the other one's a flat, and then you just cut little squares or use
I think she's been cutting that pink spot now. She's been using the.
I mean, I don't think it's gonna, it's like wax. So it's not gonna dissolve.
Make a call.
Yeah.
Password to this computer.
So I'm gonna run to the bathroom.
Remember, right, the notes I found, is it facial manipulation?
Actually. It's a little bit.
Is it what you're doing with Maribel? Because I looked at your phone.
I can look at it again. And which one I did.
Can you tell me what I can do if I see her? Because she,
Oh.
your specialist had it for her.
What's
The
the
other Friday, your time is over.
password for the
Oh,
computer
okay.
for the K6?
She likes after her school hours. Or something after she gets fancy. or
If
whatever.
she's a-
HST star 1 wasn't open.
So if you can suggest me something that I can do,
It says
I don't know facial
HST
manipulation.
star 1.
Do you know Thomas Myers anatomy term?
Oh.
Similar.
Okay.
You can Google it.
Okay.
It'll tell you like applying.
And is that what you have been doing now?
It's similar.
Keeps telling me it's not just HST 1. Or is it home sleep? It's home sleep test.
Is that what you have been doing with your user? Like gross.
Yeah, I see it. It's just not working.
Let me get my phone and we will see what you're.
Here, hold on. Let me show you. I'll give you. It says password HST star 1, but it's not working. Is the yes. Okay. So here's the keyboard. Wait a minute. Got a switch. How do I switch? What's it? Okay. It says HST star 1.
Like
Hmm.
like
Asterisk is the star, right?
Yeah. I think I remember which one it was. tongue hurt.
Oh, no, never mind.
Tongue smell.
Thank you. Go back to your
Tongue
kids.
natural line. Not nice.
Thomas Myers is a patient?
No.
Massage therapist.
Okay, have a seat here.
Remember, Dr. Gabelis was talking about the fascia.
Mm-hmm.
So for the diaphragm attaches to the tongue, so that's the deep front door.
Okay.
There's a connection from.
The only part I understood was that you need the money like the balance and everything like last week.
It's not really what we can.
It is.
That's what I'm saying. So I know that's that because I done money.
Small.
But I don't know this FM thing.
I'm
that
not
you
from
did. So I told, but I was like,
I
I
know I'm
don't-
all over.
the part that I understand.
Not
will be
that
what
one,
you
like,
have in
I'm-
copy.
My
The
knees,
rest of
my
I
ribs,
did one
and
stuff of cat and time I'm
back,
trying to do.
back. I can't do
More
that
faster
one.
extends and I do more of moving.
Yes,
So
what
that's
do you
it.
Just pass it. I'm
But
Are
some
you-
of the
are you
things like that
ready?
you don't understand. I was like, when I see you next
not
time,
even
I'm ask
yet.
you that.
I don't know.
What do you
This
think?
is and in red is anterior and retro is sagittal line.
Okay.
So it'll
I
be the
did
front
get a
and
mental
back
aid.
lines. In tongue layers.
Oh, okay.
Sagittal line.
Yeah, I got it. Yeah,
Here
you're
and
right.
here, and then just the lateral line is, you really just follow the line down.
But what did you do? Did you just get a like elbow into it?
Yeah.
Oh, okay.
Tongue layers should like literally do a myofunctional.
The whole.
It's a very dense book.
I had not. That's something you told me that now I'm going to do it.
It's easier to read than the sessions.
Okay.
Really?
Okay, so you know.
I don't use a medical.
Actually, it's terrible.
Did you see medical?
Helps other people. Sorry.
Uh,
It's like everybody.
No, if you
Don't you
really
feel
think
that
you
way?
should do it,
As a
because
therapist?
she-
If you help them,
He
they
did,
help other
she
people.
already did the MRI.
She did. She did the MRI for the neck and the lower back.
They need to understand what this is.
And brain, you know.
I think they could brain. Brain, I think, not recently came back. Maybe early last year when she first started with people. But you said it was
Fighting.
sure when they're
Yeah,
The
they're-
fight is not right now.
That's a little-
After
see what
that.
you're gonna do. No, your wife's more right.
I don't want to, I
She
said, I
doesn't
don't
have
want her.
the history of.
Don't fight, just let it hang out.
Vasectomy, right? It was only a vasectomy.
It was just a vasectomy, yeah. So she had that, the pain came back, pain, very difficult side. Some of them were in also in that. But after that, nothing was helping me, nothing was helping. She started saying me, I started doing a lot of writing, that helped me quite a lot. We did online sessions, she got a lot better. We were about to discharge her, but just because we started in the clinic, she was like, I'll come back and see you. But work started.
So does that have to align with the access?
No, just belongs to the neck.
Yeah, because I had everything what I had in my pocket and I was able to do it. So we did a lot of facial massage. And now she's feeling up. Or just tell her to see you for something because I don't know how to do
The
it.
tense has to be on too.
So
Yes. But
I
together,
think she saw you once.
I think I was
keep holding your teeth together.
So she's a really strong woman. And you can see like her analysis is really bad and she's pretty. So everything is fine when you're trying to do stuff on her. I feel like I'm really good because you have to do the lumbar moves. You have to know
I
her
see.
arm, and then you're like, oh, you can.
I'll make it good.
But, oh, in case if you
Straight ahead or liver
do
like.
you do facial massage?
not by, it's not time to open.
Right in your back.
Have you met Francis?
Put your tongue in there, on the outside. That's pretty.
Asthma?
Now slide
But I would
forward.
not have met.
Okay.
Sliding forward.
Those are Friday Ken special stations.
I'm gonna save that, but you kind of went off my screen, so I'm gonna do something.
Can
a
you
little
ask
bit
me
different.
about ID? You have to tell me. I literally took her off my. I was like, I'm sure
I
I
don't know. I don't know who.
told her what.
I was
Right together.
I told her that. Because I wanted her off my schedule and he was the only one who can tolerate. But she's done that. I recommended to the short ladies, yes, for the scoliosis assessment. But she doesn't want to do anything, she just wants dry needling. That's her problem.
I'm making her do some more exercise.
I'm glad you, I don't even succeed in her assessment, but I clearly said that she always registers.
Oh, and I know, off the back.
I'm so
Slide
annoyed.
slowly forward. Okay,
On
so
that side, you can go quick without moving her head.
I'll leave that on the ground. Let me say
You are,
this,
you are.
and then I'll just add, and then I'll show you another one that we can all look together.
My teeth want to be edge to edge right now. The jaws forward after all that tense.
So this puts it in the anatomical, right?
This puts, it just puts the jaw to the relaxed spot.
Relax.
So muscles are all relaxed. Now I said,
Then your face looks a little different.
Turn the cones off. Right together in your back teeth.
just
Right in your back teeth. All the way.
Like Tourette's.
Slowly open and close all the way. Right in your back teeth. Right? Open as fast as you can. Faster. Faster on the close. Faster on the close. Faster on the close. Good. No, okay, we'll just show you a few and we'll show you everything that's going on.
This looks like a
I didn't have to just work on.
You can take that if you want to. You might like, if you want to. You ready to have it on?
Or put it
You
back
just
on.
leave it on for a couple minutes while we go.
It's not on. Should I turn it on?
But right now, I have to put it off for the one scan. So I'm just gonna show you.
Oh, got
You know,
clear.
better with it.
Yeah.
I don't got clear.
And
Yeah,
you
it's
see-
in-
This is a jaw tracer.
This is the jaw tracker. So this
Tracker.
is one of, we're doing 2 studies of the whole possibility. So the first one didn't work out, so I redid it, but I thought I'd tell you why it didn't work out.
That's what happened.
When we did this one. So when we did this one, this little area here, this is movements of your jaw. This is up and down, front and back, side to side. Took you one off the screen. You know why you went off the screen? Because we took our baseline with your front teeth touching. So now when you get your back teeth, you're so far off of there, you couldn't see it. I'm just gonna go to the next one. I just saved it because that was a mistake and now I won't make a mistake again.
You wanted me to be in my back teeth.
I just needed to set this to you. So where your bite is so far off, it's,
Right now, it's so, I mean,
you
where,
can feel what's wrong. So here's what we're measuring. This is up and down movement. This is the pulse of the tens. So it's a little pulse. It's not moving it a long way. Usually we try to be about a 0.5 millimeter movement. This is front to back movement. So if you're pulsing, here's the joint. Up and down, goes forward and up. This is side to side movement. So there should be no side to side movement. You have more nerves in your body just close to the same spot. So now we hit close. So I'm going to switch to this one, which is the same picture. We're going to look at a little bit different mode. And look at it there. So here's the front to back movement. That's where your jaw wants to be.
from the back molars forward, that's this movement,
So here's the rest position in space.
a back teeth.
You don't have the rest of the picture.
No.
Okay. So your jaw wants to close here. And that if your muscles could close where it was healthy, you'd end up over here someplace.
To the right.
So now we're going to do redraw what happens when you close. Oops. I'm gonna pause. Slow down. Okay, so we're going to watch it in slow motion. It's nice to be able to see it in slow motion. Here's your rest position. That's where your body wants you to be.
That's the jaw relaxed, the
That's,
teeth apart.
that's where you should be
With the 10
23 and a half hours a day, 20, almost 24, more than 23 hours a day. Your jaw should be. Moves around when you're talking, but that's its relaxed spot. The It's a three-dimensional spot based on head position, but we have you sitting fairly straight and your posture straight back and your neck back into the face. So now we just let it pulse. It's going in super slow motion because originally each pulse was a second and a half, so now we're going 1/5 of that speed. But it's so you're not real stable side to side.
What do you mean by that? Like,
Well, when you're pulsing, sometimes you're a little more to the
oh,
right or a
so,
little more to
yeah,
the left.
so when it contracts, my,
So now you start to close. Right here, you start to close. The first thing you do is pull your jaw back. Now you're starting to close. Over here, you pull your jaw off to the right side. You start to close. So this is your avoidance. You've already touched your teeth. So you're going to try to avoid where the teeth don't fit right. You're going to use all your neck, jaw, and superinfrahired muscles to do that. So now we're going to close. Let's see where you actually closed. So you don't know where your at is at. Probably should have slowed it down so much.
Is this still the tense opening and closing her
This
jaw?
is the tens. This is when you start to close. You have to pull your jaw back.
I have to go back.
You have to
My
pull
jaw is
back.
forward.
So now,
Back.
this is where you start to close. That's actually a pulse. We could have turned the pulse off. And then you're working really hard now to get your jaw to close to here. So now, all these spots where you didn't know where to be, you actually close to the left of all of them. The muscles want you to close up and down straight. You have to close off to the side.
I go left in my
Yeah.
jaw when I go.
And this is where you bite to. Well, we did do a great slide forward, so I don't want to do it again, but I feel better. But now we have you slide forward. I think you opened your mouth a little when you slip forward. So ideally, you'd like your teeth to slide against each other, but they basically so bad you can't do this. This is very dyskinesia. When you try to close that there, your muscles have a hard time even putting
Didn't like going back there.
No, it never likes going back there. You're just aware of how much it hates it now.
No.
So now you start to slide forward. So this line is where your teeth are pushing against each other. You can't get to the other side of that line. So it's like, and here's where your best position was. So this whole area here, it's filled with teeth. You can't go there where your jaw wants to go. There's teeth in the way. So instead, you go forward. And you're way off to the side. So then, if you want, I can do another one, and you can probably get a better one. Now you've done it, you got a feel for what you're looking at. But I'm going to show you the next one. So, this picture, it's actually a whole bunch of pictures. So this is sagittal frontal. Were you biting on your back teeth there? You open and close.
You wanted me to stay back and then I have to go.
So we're going to just watch redraw it. I watch a little fast. If it's too slow, we'll be here forever. We'll go up to about faster redraw. Okay, so you start to open. The closed position, you open down here. This is velocity. See all this movement is not smooth. It should be smooth. If you're going slow and you're sliding off to the side. Probably an internal ranger, there's a click, like a click and a click. Those are when your disc is going backward or off. As you click, there's a change in direction of your opening. Now you're opening it smooth, not away from the disc. The end, you're kind of the end of your movement. And that's probably a little bit of an eminence. She's doing what you did, where she's sliding off to the side because of the end of the opening. Now you have to close. If you close, whoa, you're going way off to one side. Your brain doesn't want to get back. Now you kind of go back to the midline. Now you go to the other side. Now you go up and back. That's your spot. We don't really see the closing place here. When you open, we see the one line, and then if you close, we see the red line. Well, if you watch the red line, it's closing and closing, then you got to pull back. But if you got to pull back, what happens to the joint? It goes back and the thing is pressing. I'm going to continue, but just erase this and just continue going back. So now you're going to see the next one. I can go open and close on any of you just to see how you open without me.
So my jaw wants to stay forward, which is 10. But my teeth don't meet there.
Right, so now when you open fast, this looks pretty good. You come off a little bit, you don't see all the detail. You have a smooth opening on closure. Opening. You got a clip there. As you go around it, you change directions. Now you stop. You slow way down, almost to not moving right when you hit. Because that's a protective reflex. Your brain says slow down or you're going to have a sore tooth. We can continue. We did a whole bunch of open, smooth opening, slows down. Immediately on opening the side to the side. And as you close it, then there's just, it's not there. As you close, you come off to the side, but you again slow down to almost nothing. There's clip. You don't always close to the same spot. You have more nerves in your body to close to the same spot than anything else.
The last one.
So we can see what's going on. But you can't measure what you're doing, you have no idea. I can either try to get another 4 or 5 that looks a little bit more perfect, because that wasn't perfect if you'd like to see it. Or I can do just the open close on one of you. Or we can just call it a day.
So does that mean our condyle is not resting in the right position or in the same position
Yeah.
all the time?
Typically,
Because she
I
closes.
put it here. So here's one of the things I do with my patients. I'm going to put my fingers into the airway, open wide, and bite into their teeth. Now you put your pinkies in the same way. You're some part facing forward, open wide, now bite in your back teeth. You feel your condyles going into your ear?
Yeah.
Do you think your condyles belong in your ear? No. They don't. Not biting your front teeth, but it feels more comfortable.
They're not there.
Which you think is healthier?
Forward, but my teeth, I want to crack my teeth.
That's why you have to do this. You have to make it right. But if you put this in, you still want to go to the same spot. Make sense?
Yeah.
So this just allows us to actually see what's going on. We'd like it to close right on trajectory in both planes, and then when you open, we'd like to see it close fast. Anybody feel like your bite's really good? I can show you an open close real easy. You just have to include the name. Otherwise, you want me to do a 4 or 5 and see if we can get a really good tracing?
Sure. I think, so, but would
I
you
can't
have to
live
bring
with
my maxilla forward to be able to have my teeth?
Okay, so I don't have enough information. at
Whenever
this
she
point.
closes, it doesn't go back to correct to the same spot. So that means the condyle is shifting right, forwards, backwards, side to side.
Correct. But when she put the finger in the ear, what was she
Your
looking?
condyle is right in front of your ear.
So if you do this, I felt the bone going into my ear.
Oh,
You
it
feel it.
shouldn't. It should not
Put it
go.
in your, yeah, when your teeth are back on your back molar, you feel the condyle pushing into your finger. And if you do, that's not good.
Right together.
So mine is on the right.
Just bite
My
the
right
right.
side shifts back.
Okay, so ready?
Actually, if I don't
Back
deep
one.
bite, it's straight. If
Back
I deep bite, it
teeth
comes
all the
forward.
way together. None. Then hang relaxed.
Opening?
What is it?
Big opening or
No,
big
no,
clench?
deep clench. So when I bite, but I deep bite, that's when I think it's popping back.
Really?
Mhm. I mean, I do have
Bite hard
good
in the
bites, so
back.
I know that.
Now that I think about it, it's nothing. So do you do this also for sleep apnea people?
I don't do this for sleep apnea. Well, we do this different appliances. right, and then you don't open first.
Say it again.
Don't open before you bite. Right, so while your back deep, you don't really squeeze tight. Keep it squeezing tight, slide forward. So now I'll just show you, this is a more accurate one. Except you want to kind of retrain yourself to put that together.
I'm trying to do it again.
No, we're fine. I'm just going to show you one picture.
And I went past my upper teeth.
That's fine. See, ideally, there should be nothing more. So it might be possible, and it's too soon. First thing we do with everybody is we put them in appliance and straighten out the posture. Because otherwise, if you do this, you can change it.
Yeah.
But basically, you have to, if this was 100% true, every time you close your jaw, it's going to push off to the side. So what happens is, to move your jaw to the left to close, your right lateral pterygoid has to go overboard. Your right medial pterygoid goes over. Your left temporalis works a little bit, trying to reposition the jaw to that spot. If this was our final position and everything else was in good shape, we'd range it in. I don't think that would be because we can't see it. So we can also do something. I'll just show you another piece. See this straight for a second again. Okay. Together. Slowly open, close all the way. Oops, close together again. Let's do that again. Hold it. Slowly open and close all the way. And close. Slide. Just open and close. Back a couple times. Right. Slide to the right. Right. And your back feet. Slide to the left. Right. Slide forward. Okay. Let's see. So now we're just looking where you go. So what we know you should open and close straight. You should be on a thing and you should always go to the same spot. See, this is the first one. Open, you start by opening, bring your jaw forward down. You're disengaging the teeth. And you close. You close from more forward, you come in a different plane. Oh, that's a different spot. You don't open and close to the same spot. But that's okay. We'll watch what you do the next time. That may have been your front teeth you were biting on that time. Now we got a little slide to the side, a little slide forward. Now you open a small one, or you're tapping here. You kind of tap to here. That's your tapping spot. Then you have your slide right and left. It's your target, so you can't go anywhere under that line. You're going to be biting again. You try to bite way off the left. You have to go the other way. That's where your actual bite is. If you never hit that spot, you have to bite again. This side forward. So you have more nerves to close to the same spot than anything else in your whole body. When you do this, you don't close to it. Let's take it. Exit, redraw. Exits. So here's where you do most of your closing. Here's a difference back to close. Here's a difference back to close. That's where you close all the way. That's where your real bite, where your teeth is.
Where?
Right up
Yeah.
here. You make that. So you'll close here or here or here to avoid it. So why do you make that? Because that's where your jaw joints are in your ears.
Mhm.
Your jaw joints belong in your ears. Even if you don't consciously think about it, you think your brain knows your jaw joints don't belong in the ears. So here, this is where your teeth are all the way together. It's way off to the side, to the left, almost half a millimeter, maybe a little more than half a millimeter to the left. When you tap, you have this big wide area, but one time you won't close to here, and another time to here. So you know how they do this to see if you're drunk? You put your fingers together? Yeah, if they were checking your jaw, they'd lock you up. You've got more than half your nervous system is designed just to hit your teeth in the right spot. And you can't do it. Anybody else want to see what theirs looks like? Yours is probably the worst.
No. I think I'm.
I think they have to go.
Okay.
So,
Little kids at home.
yes.
Your husband's dealing
My-
with a little one,
yes.
right?
Yes.
Is he going to have a breakdown?
No, I think she's.
That's what happens after he gambles the family money away.
Close to divorce him right now.
Do you want me to just take this off?
I won the 200 million
Maybe.
from the lotto that he won, by the way. And then he do whatever he wants.
Technically, if you divorce him, you get half.
You're right. You're right. Right? I'm back on the market. You're right.
Oh my gosh,
So-
this was amazing.
Usually it's 90 minutes to 2 hours. Sometimes they run late. I have a hard time staying on time
Oh, yeah.
because I think everything is important.
Mhm.
I can do the waxing for you and take off all your facial hair, or I'll let you take it off yourself.
Thank you.
I have it.
You'll feel like you need the appetizer more. Who snores here? Anybody?
What is it?
Anybody snore? Do you snore?
I don't snore.
I've never heard myself snore.
My husband snores though.
You're a clencher, let's see. Nice. Oh, he's a clencher. You know what a clencher feels like? Fingers are. Right hard? That's the clencher. Put your fingers here. Clench hard. Where you bent up anywhere else in your body.
I wish.
That's a bad clencher.
It's actually better now.
It used to be that, that's what he said.
The worst of all was John McCain. You ever watch him on TV with his muscles?
Oh, yeah, yeah.
He
that
used to
was
go
really-
mile out.
Yes, I remember him. All right, Dr. Shapira, thank you so much.
I mean, we could keep talking forever, right? Thank you for your time.
You're
You're
welcome.
awesome. Thank you for listening to the Breathing Lab with Dr. Jenny.